it goes away from the predetermined path, it is going to inform me. So I can avoid all these. So this is all the paraphernalia. I'm just going to skip that. So this is the machine that we have used intra-op. This is, you can see me in the surgery. So similarly, navigation we have also used in this distal femur case to plan our very close margins where we need margin of 1 centimeter or less. As I've already told you, growth plate is a good enough margin. So here we were able to salvage the joint in this case of osteosarcoma. Fine. Another one is rotation plasty. I'll just show you the slides. Rotation plasty is in which we make the ankle joint as knee joint. These are the images better explained so that the patient can walk on. This is basically to convert above knee amputation into below knee amputation. I'm thankful. Thank you so much. Thank you for such patient hearing. I must say that I treat adults as well as children. So children are much better patients. And this is always a pleasure to treat a child with sarcoma because when we preserve limbs, we are preserving their hopes, happiness, as well as their livelihood. Thank you.
Thank you, Dr. Akriti, for an excellent presentation and best wishes for all the good work that you're doing. Can we allow one question or do we proceed? Huh? Okay. For lack of time, we will. Okay. Sir wants to say something.
Dr. Akriti, is there any role of stem cell preservation for the reconstruction surgery of limbs?
So when I was in AIMS, yes, there is, because there are million of possibilities. Because when we, in cryotherapy, when we do the treatment or in extracorporeal radiation, the bone essentially dies. So there are much more chances of reunion. Stem cells can be used to ensure union as well as for recreating the joint capsule and cartilage. I mean, yes.
So I would like to invite our next speaker, Dr. Rohit Kapoor. He'll be talking on the approach to round blue cell tumor, a very important topic in pediatric oncology. And he's a consultant in pediatric hematology oncology and BMT at Max Hospital, Vaishali.
Thank you very much for the organizing team to call me over here. And today actually we would be discussing about the approach to the round blue cell tumors in the pediatric population. So the key learning objectives over here would be that we have to first know that all the round blue cell tumors look like the same, but we need to see where exactly the biopsy is being taken from, what is the age group from which the biopsy has been taken from, and what is the clinical presentation of the patient. And so first the learning objectives would be to know and to translate the small blue round cell tumor to a particular diagnostic and treatment pathway. So first we need to see the clinical pattern, then we have to use the biopsy specific algorithm, then we have to see the IHC panel that would be best fitting based upon the clinical status and the age of the patient, and then we need to see whether we have to put molecular tests or not. And the key thing over here, we do not have to diagnose a pediatric round blue cell tumor by morphology alone. So why exactly the small blue cell tumor, why it exactly matters? Because the histopathology specimen looks the same, but the treatment may be different based upon the origin, the age, and the presentation, and the chemotherapy is altogether different. So basically they have a shared morphology, and they are small cells, hyperchromatic, with a hyperchromatic nuclei, and scant cytoplasm, high nucleocytoplasmic ratio, and frequent mitosis, and that's why they are called small round blue cell tumor on histopath. So the differential diagnoses are Ewing's, peripheral neuroectodermal tumor, rhabdomyosarcoma, synovial sarcoma, non-Hodgkin lymphoma, retinoblastoma, neuroblastoma, hepatoblastoma, nephroblastoma, and rarer variants are small cell osteogenic sarcoma, undifferentiated hepatoblastoma, granulocytic sarcoma, and intraabdominal desmoplastic small round cell tumor, which are generally seen in the males. So treatment changes based upon the diagnosis, because the age, the location, the whether we have to do surgery first, or whether we have to do chemotherapy first, or whether we have to do biopsy followed by any other the treatment would depend upon the location, age, and then once all the data is in our hand, then we can go ahead with the accurate management. So first, H&E pattern, as I discussed, the clinical context, then the IHC and molecular pathway have to be put in based upon the clinical context of the patient, and then the final integrated diagnosis would be made to treat the patient correctly. So first, as I already mentioned, the age, site, imaging, the serum as well as urinary markers, morphology, IHC, flow cytometry in lymphomas, and molecular genetics would be needed in the tumors or the lymphomas. That would lead to a unified diagnosis, and then we can treat based upon the diagnosis made. So we have to avoid a single marker diagnosis like CD99, Desmin, NSC, synaptophysin, VT1. They all have pitfalls. So first we have to see the age, we have to see the clinical presentation of the patient, and we have to see the anatomical site. So this actually narrows the diagnosis, and it also narrows the IHC. So because we cannot use, because of the cost constraints, the IHC has to be focused. So if there is an infant or toddler having a adrenal or paraspinal mass, we would think about neuroblastoma, and the useful clues are MIBG, avidity, catecholamines would be seen in the urine and blood, and marrow metastasis can be there. So bone marrow studies may be needed to see for infiltration. If the child has a kidney lump, the Wilms tumor comes into the mind. So based upon that, the origin would be renal. It has a triphasic histology. VT1 and PAX8 are the important markers. Bone, chest wall, deep soft tissue. They include Ewing sarcoma family. The presentation is fever, pain, lytic lesions, CD99 positivity, and ESR1 fusion is there. In head and neck location and GU location, extremely soft tissue location, rhabdomyosarcoma is important, and Desmin, myogenin, and myod1 are very important. Nodes, mediastinum, and marrow, if they are involved, then it is leukemia or lymphoma, and CD45 is a very important marker, and flow cytometry needs to be done, and TDT needs to be done. If there is eye, then retinoblastoma, it presents as leukocoria. Liver mass, it presents as increased AFP. And so what red flag signs and first workup we should start. First, first we have to always stabilize the patient. If the patient is having a oncological emergency like airway compression, like T-cell lymphoblastic lymphoma, or compression in the airway, or spinal cord compression due to neuroblastoma, or very high tumor fraction because of high grade lymphomas, which all have small blue round cell, or renal failure due to TLS, or renal tumor itself, or severe cytopenias, they have to be managed first by blood platelet transfusions. The spinal cord compression would need steroids. Airway compression, you sometimes would need some radiation, or some steroids to decrease the mass, and we have to do the baseline labs like LDH, uric acid, CBC, renal and renal profile, beta HCG, alpha fetoprotein, and urine specific biomarkers may be needed in the case of neuroblastoma, AFP for hepatoblastoma, marrow examination for lymphomas, neuroblastoma, and Ewing staging, and imaging should be done before the biopsy to look for the spread. So MRI for local soft tissue or cord, CT scan when sarcoma is suspected, and ultrasound CT scan for renal or liver masses. So practically we have to see, first we have to have an adequate biopsy specimen, and it should be a fresh sample. H&E staining should be done, and the site as well as age should be mentioned along with the performer, so that we can know what our focus is, and based upon the site as well as age and H&E pattern, the IHC lineage can be put, and flow cytometry, which is very very important in lymphomas, CD45, which is the actually filter, and that if it is ruled out, then we have to go for, or it is ruled in, we have to go for molecular test or fusion or driver testing as necessary. If CD45 is positive, then we have to go for flow cytometry, marrow and CSF studies. If Desmin or myogenin markers are positive, then we have to go for rhabdomyosarcoma, and we have to go for fusion studies for FOXO, PAX3, PAX based assays have to be done to see for the prognosis. If CD99 membranous is present, then we have to go for to rule out, we have to rule out Ewings. So, and we have to do fish, and we have to rule out CIC and BCOR mimics as well. So we have to, the key thing is ki first biopsy is the very important biopsy, and enough material should be there for IHC, cytogenetics, fish and NGS, and even biobanking if future molecular studies have to be done. So before you go ahead with the biopsy, the surgeon has to, surgeon, radiologist, pathologist, and pediatric oncologist should make a team to see how the biopsy has to be done, whether the biopsy tract has to be removed along with the surgery, whether the image guided core biopsy has to be done for the deeper masses, or FNAC would be enough. During biopsy, core biopsy is preferred and necrotic areas are avoided. That would be told about by the radiologist. And the key thing is we have to know whether the patient has received steroids or chemo or not. And we always have to send the fresh material for flow cytometry if lymphoma or leukemia is there, and fish and NGS or if sarcoma or neuroblastoma is suspected. And we have to see the biopsy planning has to be done with the surgeon, so as to have least excision as possible, most conservative surgery as possible. So first of all, we look at the morphologies after the biopsy. It is a helpful clue, but it would guide along with the age and the location of the biopsy. It would guide the IHC panel. So if Ewing's sarcoma is there, uniform cells, sheets and lobules and glycogen and necrosis would be there. Neuroblastoma, neurophil, humor, right roseates are there. Ganglionic differentiation is there. In rhabdomyosarcoma, rhabdomyoblasts and alveolar or pattern may be there. Cambium layer can be there. And in lymphoblastic lymphoma, starry sky pattern would be there, and the biopsy specimen would be from a node. In Wilms tumor, triphasic or blastema, epithelial stromal elements would be there. So morphology based upon the location would should trigger a IHC panel, and that would tell what first line IHC have to be put. Like if the hematolymphoid neoplasm lymphoma we are suspecting, then CD45 is important. TDT, CD3, CD20, PAX5, CD34, MPO. If it is myogenic, then Desmin, myogenin, and MyoD1. If neural, synaptophysin, chromogranin, NSE, FOX2B. In Ewing's, CD99, NX, NKX 2.2, FL1, and we have to do the fusion testing as well. If epithelial, renal or germ cell are involved, are thought about, then cytokinetin, EMA, VT1, PAX8, AFP, and these markers are needed. In melanocyte, if tumors are suspected, then S100, SOX10, Melan A are indicated. So what are the pitfalls? So in these markers are basically clues, but the thing is, alone single marker is not suggestive of any particular kind of tumor that we are thinking about. So multiple markers have to be taken into consideration before making a diagnosis. So strong membranous CD99 is positive in Ewing's, but it is not specific. So it can be seen in synovial sarcoma and lymphoblastic lymphoma. Desmin alone is insufficient for RMS, and the nuclear myogenin is also decisive. So synaptophysin NSE can be non-specific. We have to correlate with FOX2B, chromogranin, and clinical as well as imaging studies. VT1, alone, it is not contributory. We have to see whether it is what sort of pattern of staining is there, whether it's nuclear or cytoplasmic. And KI fraction will tell the aggressiveness, but it is not the linear specific. So best practice is to report it as a combined panel rather than isolation. And when exactly molecular testing is preferred, once if the IHC is not conclusive, then we have to do the molecular or fusion studies. Like in Ewing's sarcoma, EWS-R1 and FLI1 or ERG fusion, we have to see for those. In BCOR altered sarcoma, we have to see for BCOR, CC and B3 or BCOR ITD. That can mimic Ewing's, and they are very, very close differential. Neuroblastoma, MYC amplification, loss of segment loss of chromosome can be seen. CIC rearranged sarcoma, it is often CD99 patchy. BT1 and 84, they may help. And in RMS, PAX3, PAX7, FOXO fusion tells, and it tells that it's an alveolar rhabdomyosarcoma or not. So fish can be used, and NGS and RNA fusion panel, is when phenotype is like ambiguous, and if the tissue is very limited. So first, if the round blue cells are seen in the tumor, then we can put these basic markers. CD45, it is positive. Then we have to think in direction of lymphoma, myogenic rhabdomyosarcoma, FOX2B neuroblastoma, CD99 Ewing's, VT1 PAX8. It would be organ specific renal, liver or germ cell tumor. So coming to the quick common tumors, Ewing sarcoma family and undifferentiated round cell sarcoma. They are seen in older children, adolescent, and a deep painful bone or deep soft tissue masses are there. It can be present in pelvis, femur, chest, and paraspinal sites are common. And the key thing is that it is membranous CD99 along with NKX 2.2, which is very important marker for Ewing's, and molecular conformation can be there by fusion studies. And we have to rule out CIC rearranged sarcoma, Beaker altered sarcoma, and EWS R1 non-ETS fusion tumors that may resemble Ewing's but are just separate WHO entities. So rhabdomyosarcoma seen in young children, fusion studies are important. Vimentin as well as MyoD1 are the important markers, and Desmin supports myogenic lineage. And the decisive markers are nuclear, myogenin, and MyoD1. This strongly support rhabdomyosarcoma. So these are the key things that we have to do, that we have to see the context of the patient and see the staining pattern. So coming to neuroblastoma seen in infants and young children, adrenal or paraspinal masses are there, anemic amplification is there, segmental chromosomal aberrations are there, and the markers are FOX2B, synaptophysin, chromogranin. S100 highlights sustentacular cells in the ganglion neuroblastoma, and useful tests are urinary VMA, HVA, and MIBG scan when available, and marrow aspirate and biopsy for staging. So the clinical pearl over here is neutrophil, and FOX2B is more specific than NSE positive. So in leukemia and lymphoma, they present as a mediastinal mass. CD45 is a very important marker to distinguish whether it's a hematolymphoid plasm, and we have to avoid steroids before we are going ahead with the biopsy. Renal round blue cell tumors, these include Wilms tumor, malignant rhabdoid tumor, clear cell sarcoma, and primary renal Ewing sarcoma. And for all these things, we have to see for molecular studies or fusion studies for rearrangement to distinguish it from Wilms tumor. And organ specific tumors would depend upon the in hepatoblastoma, few markers may be raised like AFP, that would be raised in medulloblastoma. The clinical presentation is important. Sometimes posterior fossa excision biopsy is important. York-Sack tumor, AFP, serum beta HCG, all these markers are important. And in retinoblastoma, flexural ventrosternal rosettes are important. And so rule of thumb is an organ specific tumor can look for undifferentiated on small biopsy. So first we have to see the origin, and then we have to do an urgent intervention if needed, and whatever tissue is left, we have to keep it for molecular testing and clinical trial if we are unable to find the diagnosis. Staging can be done after the diagnosis, and we can go ahead with the treatment based upon the staging and the correct diagnosis. So the simple mnemonic is blue cell, biopsy that should be adequate, location, urgency, essential labs and imaging, CD45 to rule out lymphomas, Ewing's, RMS and neuroblastoma IHC panel. Lineage has to be confirmed with molecular if IHC is not conclusive, and linked to diagnosis based, and then we have to give the treatment plan. So this is one slide that tells everything and summarizes everything, and it's a flow chart for diagnosis of small round blue cell tumor by immunohistochemistry. And so take home messages over here are: round blue cell tumor is a pattern, not a final diagnosis. We have to use a broad IHC. Fusion studies have to be done post IHC if needed to see the aggressiveness, and we have to preserve tissue for flow cytometry, molecular studies, and clinical context dictate the diagnosis and the treatment. Thank you.
Thanks, Dr. Rohit, for such a lucid talk. I have a question in my mind, because most of these tumors, they occur in pediatric age or early adolescent. Do we have some genetic markers which can predict these tumors, set of tumors, antenatally?
Antenatal prediction, you can, there's in B cell lymphoblastic leukemia, there are certain set of actually this disease occurs in utero itself, the B cell ALL. So the certain actually rather than markers, I would rather say to see the clinical presentation of the child once the child is born, to look for the signs and symptoms. If the tumors are or the cancers are running in the family, then we can do the molecular studies in the sibling, because the risk may be higher. So, and
like sampling chorionic villus sampling or
CVS can be, yeah, CVS can be done, amniotic villus sampling can be done, and the thing is, we can also the tumor syndromes like Leaf-Romani syndrome or the Turcot syndrome, all those brain tumor related syndrome or Wilms tumor syndrome, which have deep penetrance. If they are occurring in the family, the CVS should be done to see whether these mutations are there or not. In the amniotic villus sampling should be done to see whether these mutations are not, to predict the diagnosis early on.
Okay, thank you, Dr. Rohit. You have very nicely presented this dilemma. This round blue cell tumor is a dilemma for the pathologist as well as for the treating physicians, and you have very rightly gone through various algorithms, crisscrossing a very fine line of navigation and to reach a final diagnosis. And I think the standard practice is still a multidisciplinary tumor board for an approach in this case of round blue cell tumor. Thank you again.
Thank you, sir.
Now, I would like to call Dr. Sumit Gupta sir on stage for next panel discussion.
Good afternoon, everyone. For the panel discussion in management of brain tumor, my panelist is Dr. Deepak Gupta, Dr. Avinash Sharma, Dr. Pankaj Gandotra, Dr. Sanjay Kumar Chandel, Dr. Aditya Srivastav. ये नहीं है, ये नहीं है मेरा, हाँ फुल कर दो. For panel discussion, my topic is pediatric brain tumor. I am hearing some few cases of pediatric tumor, and which are usually treated by us in our regular OPDs. This is a case of 7-year-old boy presented with the progressive headache for the 3 months, early morning vomiting, unsteady gait, declining school performance, and on neurological examination, truncal ataxia, horizontal nystagmus, and papilledema. On the MRI, which show 4.5 centimeter lesion midline posterior fossa, mass arising from the cerebellar burmese, and with the complaint of showing obstructive hydrocephalus, no obvious spinal disease. What would be the, this is the for the panelist, what would be your probable diagnosis and first line of first step for the management? Anyone, sir. I would like to prefer Dr. Avinash, sir.
Hello. Good evening, everybody. The MRI wise looks like a already written in the paper,
Yes,
is already out.
Yes, sir.
It's written this is a medulloblastoma and it looks like a medulloblastoma. Patient having hydrocephalus, but it is not very severe hydrocephalus. So I think we should go for direct posterior fossa suboccipital connectomy and excision of the tumor.
Okay. The answer is medulloblastoma, as said by the sir, and with the maximum safe resection.
Yeah.
After resection, the histology was classical medulloblastoma, and post-op MRI suggestive of residual disease with the less than 1.5 centimeter volume. CSF cytology negative, molecular testing, VNT activated, TP53 wild type, risk stratification, standard type.
Because it's a WNT activated, so it's a very aggressive tumor.
Yes, sir.
And I think patient, although all patients of medulloblastoma need radiotherapy and adjuvant chemotherapy, so I would like to tell our panelists what is their opinion.
On risk.
So it is WNT activated. WNT, if you see the molecular classification of medulloblastoma, there are 4 types: WN2, WNT, SHS, group 3 and group 4. And it is WNT activated less than 16 years of age, so it's a favorable risk group, a standard risk group.
So according to our cases, this is a standard risk medulloblastoma more than 3 years of age, gross or residual disease is less than 1.5, and VNT activated and TP53 wild type. So what is the probable question to the radiation oncologist? What think about the CSI?
So even it is WN2, because if you see the data from medulloblastoma, people have tried to reduce treating the brain, posterior fossa, but the standard treatment, because they have burned their hand, the standard treatment for medulloblastoma standard risk group is craniospinal radiation, and probably with, as this is a favorable risk group, you are going to give a less dose, not 36, probably 23.4. There is a trial which is going on Tata Memorial. If you see the trial, they are further, because this is a favorable risk group, they are trying to further reduce the dose to the close to 18 gray, but that trial is still on. So at present, the standard would be a 23.4 gray, followed by boost to the tumor bed and craniospinal radiation. Regarding in terms of
is it spinal radiation is eminent or not, just like?
Spinal radiation is mandatory, because if you see the data from Parker studies, in which they, even there is a ACNS study 00331 in which they try to omit the spinal radiation, but the failure rate is quite high, because the medulloblastoma do spread from the brain as well as from the CSF fluid. But they also compared, you can reduce the posterior fossa boost to the tumor bed boost, which has been, the equivalent outcome, but you cannot omit till date, even with the use of chemotherapy, the spinal radiation in case of medulloblastomas. In terms of proton versus photon, yes, if you have proton, you should use protons, because that help to reduce the doses to critical structures as well as the normal structures. So if you have the proton, that's it. Regarding molecular subtyping, because it is a WNT, this is already you have classified as WNT. So it's a favorable risk group. Molecular classification now is the standard to classify the patient, standard risk, average risk, because there are 4 or 5 categories now has been defined. And
long-term
regarding long-term neurocognitive toxicity, the advantage of proton is there. The advantage of proton is there over the photon therapy.
As we discussed, the CSI dose are set 23.4 in 13 fraction to boost to the cavity, up to the 55.8, and proton therapy is better if it is available, and molecular testing by the VNT is a favorable type, and with the higher use of technique we go for the reduce the neurocognitive toxicity also. This is the another case, 9-year-old girl present with the facial weakness, diplopia, difficulty in walking, progressive symptom over the 6 week. On neurological examination, 6th and 7th nerve palsy and ataxia. On the MRI, diffuse pontine enlargement with the lesion. Probable diagnosis, anyone?
It's diffuse infiltrative pontine glioma. It's grade 4, almost in old and new classification. And next step we have to go for contrast MRI study, and we have to just rule out whether it is mostly diffuse, they are not taking contrast uniformly. If they have some places we are taking contrast, or we have sometimes like lateral position, we have place like we got some contrast enhancing place, we can go for neonavigation guided biopsy. But universally what we are following here in most of the institute in this country, we are directly going to get going to get for that radiotherapy directly without preferring stereotactic biopsy, because most of the places, in fact, we have frame guided stereotactic biopsy frame. So in that case, it is not safely possible to take out biopsy in infratentorial, especially midline infratentorial. Above the pons, we can go through this frontal burr hole, we can take biopsy. And some places people are for experimental basis just taking this neuronavigation guided. So in our place we are just
generally we are not doing.
We are just go for this radiotherapy.
In diffuse pontine glioma, it's our protocol is not go for any surgery, go for directive radiotherapy. But if lesion is exophytic or there is interesting lesion which is having some cavity on some nodule, then we are regularly doing surgery, and we are working in the same department. We have the very good results, and some of our patient, one of my patient has done the IIT and he is working in the some company also. But in diffuse glioma it's very difficult, and mostly we refer case to the radiotherapist for radiation. And what's your opinion, sir?
So if biopsy is possible, yes, it should be done, because it not only help to differentiate the grade of glioma, although MRI you look like it is an enhancing tumor, so probably it looks like to be a high grade tumor. And if biopsy is possible, yes, it should be done, because there are molecular mutation which probably newer drugs are coming, and that will help to again treat the, because it is a high grade. If you even if you treat, the chances of the outcome is poor. So probably there are few drugs now has been come from certain mutation that will help in such group of patients. So if possible, yes.
But I want to tell one thing. If after discussion with the family, and we have explained all risk and prognosis, and they are not willing for this surgery and biopsy, so what will do?
So suppose if biopsy is not possible, at high risk, if the surgeon is considering the risk, the family
Yes.
is refusing, then there are certain cases considering high risk, and after taking a consent, patient looking at the imaging parameters, it can be taken. But these are done rarely nowadays. Most of the patients do undergo biopsy.
At least we have to require 2 neurosurgeon opinion before the taking in the radiotherapy with the negative consent. Biopsy, these are the questions already discussed. Biopsy is for the only specific center. If possible, we have to go for that. Otherwise, we can go for the directly to the radiotherapy. Thank you all the panelists for the here.
Okay.
We have to close it here.
Dr. Rohit Kapoor, sir, if he is available in this hall, please join us on stage. Now I will request the chairperson of our next session, Dr. Shweta Pathak ma'am, Dr. Amardeep Pathak sir, Dr. Sanjay Dhavle sir and Dr. Rajiv Sagwaria sir to please join us on stage.
I would like to invite Dr. Gaurav Kharia, who is co-founder and director of Celogen Therapeutics Private Limited and Director Center for Bone Marrow Transplant and Cellular Therapy. He has done his MBBS from Jabalpur and DCH from Gorakhpur. He is DNB in Pediatrics and he has done fellowship in Pediatric Hematology and BMT from Imperial College London.
Will you, is this okay on a slide mover? Yeah, slide show. Right. So, good afternoon, everyone, and thank you, the entire sort of scientific team of this hospital for organizing such a wonderful conference and for having all of us here. It's really very reassuring to see a dedicated pediatric hemato-oncology conference happening in cities like Gwalior or Jabalpur or Bhopal or Indore. So I've been asked to talk about bone marrow transplant, which is a very critical component of pediatric hematology and oncology. And I'll be just covering the basics of bone marrow transplant. So multiple diseases, one cure, bone marrow transplant. What should be a physician or pediatrician's perspective? These are my disclosures. So along with my clinical affiliation, I'm also a co-founder and director of this dedicated cell and gene therapy startup, which is Celogen Therapeutics. And the intent here is to come up with innovative and indigenously developed cell and gene therapy solutions for various malignancies as well as for benign disorders. So this is a quick overview of today's presentation. We'll drill into history, look at the basics of BMT, the timeline, what is the timeline of transplant, what are the challenges, factors affecting the outcome, indications of bone marrow transplant, how are the changing sort of donor preferences, how haploidentical transplant has evolved over a period of time, and then we will move on to disease-specific considerations with specific focus from some of the Indian data available. Now, history for any procedure is very, very intriguing. So is the case with bone marrow transplant. So as you can see in these two pictures, these are in these two pictures you can see on the left side is Sir E. Donald Thomas, who is known to be the father of bone marrow transplant, and he received Nobel Prize for his pioneering work in bone marrow transplant. And on the right side is French oncologist Georges Methe, who further ventured into the nitty-gritties of immune system post bone marrow transplant and coined this word graft versus host disease and also this adoptive immunology. And as we most of the people who are well versed with the transplant, they know that it is all about exploiting the adoptive immunotherapy in today's day and age when it comes to bone marrow transplant. Now, stem cell therapy and stem cell transplant. So this is something which I always want to very clearly delineate. So these are very interchangeable terms. So a lot of people come to us that can we do stem cell therapy for thalassemia? Can we do stem cell therapy for sickle cell disease? But these are two very different. And the basic difference between stem cell therapy and stem cell transplant is use of non-lineage specific cells to cure various diseases is therapy, whereas stem cell transplant is use of lineage specific hematopoietic stem cells to cure one or other diseases. I just want to be sure, is the time right? Is it 20 minutes or 15 minutes? I just, sorry, no, it was 20 minutes, isn't it? So that's how. Oh, so I mean, I just got confused. Okay, so what we already know, so bone marrow transplant, hematopoietic stem cell transplant, and stem cell transplants are interchangeable terminologies. And when we talk about the details of transplant, we have autologous transplant, we have allogenic transplant. Autologous is nowadays called as high dose chemotherapy and autologous stem cell rescue. So it's a misnomer. It's just a way of giving high dose of chemotherapy, whereas avoiding any significant damage to the stem cells. When it comes to allogenic transplant, as the name suggests, we need a donor. The donor can be a HLA matched sibling donor or HLA matched family donor or HLA matched unrelated donor, or in today's day and age, partially matched family donor. Cord blood transplant I have put down in the list because this is now sort of fading away, and we do not offer cord blood transplant because of success of the other three modalities which I have talked about. When we talk about the source of these stem cells, from where can we get these stem cells? Either we can get them from the bone marrow or from the peripheral blood, and cord blood, as I said, is less often used nowadays. Now there are some basic differences which we need to know. What is the difference between a solid organ transplant and bone marrow transplant? So I mean, when it comes to transplant, a broad understanding is that it will be same as solid organ transplant, but there are very critical differences. The first one is that the bone marrow transplant is governed by the blood transfusion laws, not by the organ transplant laws. What does it mean? That for an organ donation, the patient should be a minimum of 18 years of age, okay? But that doesn't hold true for bone marrow transplant. In bone marrow transplant, patients as young as like 1 year, 2 years can also be donor. All right. There is no risk to the donor. In bone marrow, in solid organ transplant also there is no risk to the donor, but in bone marrow, whatever is being donated is replenished within a matter of hours. So there is no permanent loss, there is no risk to the donor, the recipient doesn't go to operation thesis, there is no major surgery which is involved, and there is no need of lifelong immune surgery. This is another beauty of bone marrow transplant. So for solid organ transplant like kidney transplant, these patients have to be on lifelong immune suppression, whereas for bone marrow transplant, these patients are on immune suppression for a very short duration, maybe 6 months, 9 months, or 1 year, or even shorter, and after that they are free of all the medicines. Now, what is bone marrow transplant and how is it done? So basically, this is a pictorial which I very well relate to when we talk about bone marrow transplant. So if we have suppose if we have a piece of land which is growing some weed, and we want to put some useful seed in that piece of land, what is required? First of all, we need to get away with that weed, and then we put these seeds. So how to get rid of the weed? Either we plow the field or we burn the crop, okay? And that's what we do here in bone marrow transplant. Suppose a patient is suffering from thalassemia, which is like weed, or sickle cell disease. We first of all give chemotherapy, we wipe out the defective bone marrow, and then we collect the fresh stem cells from the donor and put it, and they are infused just like the blood transfusion. These cells go and settle down in the bone marrow and then start proliferating. Why bone marrow transplant? As I said, bone marrow transplant is an integral part of pediatric hematology and oncology. Many of the diseases, the treatment is incomplete without offering a bone marrow transplant, such as thalassemia. We know that the only curative modality for thalassemia, curative modality awaiting a wider application of gene therapy, is bone marrow transplant. Same holds true for sickle cell disease, for severe aplastic anemia. So basically, pediatric hematology is incomplete without bone marrow transplant, and same is the case with oncology. For high risk blood cancer, high-risk lymphomas, there's no other choice. I mean, if they are non-responsive to high-dose chemotherapy, then we have to offer them a bone marrow transplant. So all these three modalities are interlinked, and that is why it is essential to know about bone marrow transplant when we talk about pediatric hematology or pediatric oncology. Autologous bone marrow transplant, as I highlighted earlier, it is a misnomer. It is actually using your own cells. So it is nowadays called as high dose chemotherapy along with autologous stem cell rescue. So if a patient needs a autologous transplant for say high grade lymphoma, his own stem cells are taken out, they are collected, they are preserved for some time in the blood bank. the patient receives chemotherapy and then these cells are given back. This helps in two ways. First of all, the patient is exposed to high dose of chemotherapy, so the cancer can be wiped out. And secondly, the delay in recovery is not there because these stem cells have been preserved from the exposure to chemotherapy, and they actually replenish or regrow very fast. Allogenic bone marrow transplant, where a donor is required. So we need a patient is there suffering from XYZ disease. We have a healthy donor, which can be a sibling donor or a family donor or an unrelated donor or even a partially matched family donor. And using this donor, after preparing the patient by giving chemotherapy or plus minus radiotherapy plus minus serotherapy, we do the transplant and then wait for the recovery to happen. I'll take you through the timeline of transplant. How does it happen? Now, these are some of the basics of allogenic transplant, which I'll not go into the nitty-gritty of them. So, for any patient to undergo a transplant, chemotherapy is must, because many parents come to us that if a transplant has to be done, say for thalassemia, can it be done without chemotherapy? So that is not possible. Chemotherapy is essential, but this chemotherapy is different from the other chemotherapies which are used for various oncological diseases. This is a timeline of bone marrow transplant. So if we have a patient for bone marrow transplant, our preparation starts roughly around 8 or 9 days earlier, when the patient is admitted, receives the chemotherapy for 7-8 days, so that the defective bone marrow can be wiped out. And on day 0, the fresh stem cells are taken from the donor and they are infused just like blood transfusion, and then subsequently we wait for around 2 weeks for the new bone marrow or new stem cells to settle in and then start working again. So this is in a nutshell. But for majority of diseases now, we start the preparation well in advance. So it's not just day -9, day -8. We start the preparation around 2 to 3 months. So for thalassemia, the success of transplant depends on how well prepared the patient is, and that preparation doesn't happen in 5, 6, 7 days. That preparation takes around 2 to 3 months or maybe even longer. When we talk about the post-transplant care, so till day 100 is considered to be the immediate post-transplant period, because day 100 is considered to be the hallmark to tell the success of transplant. But the long-term follow-up goes on till 1 year and 5 years, because the purpose of offering a transplant to any pediatric patient is just not to make him disease-free, but also to give that particular child a good quality of life. A quick look at how we do this process, how the stem cells are harvested. So as I said, it's not a major surgery, neither for the patient nor for the donor. The stem cells are collected just the way we collect the platelets during the dengue season. So platelet apheresis done using the same machine, we do stem cell apheresis, although the kit which is used is different. So that is the commoner practice now, but in some of the patients, some specific indication, we still prefer to do the bone marrow, and bone marrow harvest is also not a challenging thing. It takes around 15 to 20 minutes or maybe half an hour to collect the desired amount of stem cells. Now, since the birth of transplant, which goes back around 5 to 6 decades, the goal has been to achieve a stable engraftment with low toxicity and high anti-tumor effect, but only recently significant progress has been made to achieve both these objectives. What are the main challenges with the bone marrow transplant? Two main challenges. Whenever you give a new system, so the main thing is whether the system will be accepted or not. So graft failure is one big challenge, and as the HLA disparity increases, the chances of graft failure also goes up. Second is graft versus host disease. So when the new system goes inside, there is always a chance of sort of fighting between the new and old system, which is called as graft versus host disease. So these are the two main challenges which we have to address, and this is done by modulation of the chemotherapy and serotherapy, so that we achieve a balance between the effector T cells, which are the cells causing either graft failure from the host or from the donor, and the T regulatory cells, which actually provide a buffer or a balance in the system. And the overall objective is that both these systems live in harmony ever after. Now, what are the factors which can affect this? So, disease-related factors. So, the preparation for a patient suffering from thalassemia will be different from a patient who's suffering from severe aplastic anemia, will be different from a patient who's suffering from acute lymphoblastic leukemia. So, disease is one thing which decides how we plan our transplant. Donor, again, if we have a full HLA matched donor, the preparation will be different. If we have full match unrelated donor, the preparation will be a little bit different. If we have a half matched donor, the preparation will be different. And so based on these two factors, the disease, The donor, we plan our conditioning and subsequently GVHD preventive strategies. Coming to indications, so in a nutshell, I would say any disease which is affecting either individual cell lines, either the red cell series or white cell series or platelet series or a combination of them, is an indication for bone marrow transplant. And when I'm talking about affecting, this should be permanently affected. Say for example, red cell, thalassemia, sickle cell disease, commonest. White cell disorder, leukemias, immunodeficiency states, platelets, congenital amegakaryocytic thrombocytopenia. So anything, any of disease, the permanent solution is bone marrow transplant. So this is a rough commoner indications which we see in a day-to-day practice in pediatric as well as the adult patients. This is the list approved by ICMR. So ICMR has HSCT transplant guidelines, and this is the comprehensive list for indications for pediatric transplants. As you can see, leukemias, chronic leukemias, acute leukemias, myelodysplastic syndromes, and various immunodeficiency, bone marrow failure states. So all are included in this. Now, when we talk briefly about the donor, initially it was like the only possibility was when we have 100% HLA matched donor, but that is the possibility only in 25 to 30% of the patients. Rest 70% will not have a HLA matched sibling donor. So what to do with these patients? So unfortunately, around 2 or 3 decades back, these patients were left to their destiny and nothing was done for these patients. But over past 2 to 3 years, a lot has changed. The donor options have increased significantly because of the registries, unrelated donor registries. We are able to find unrelated donors for a number of our patients, and if that is also not possible, this modality of using a partially matched family donor has come up a long way, and now in today's day and age we can say that if any patient needs a transplant, we can safely offer transplant using either of the 3 donor choices. If a haploidentical transplant has, as I highlighted, has come in a big way, because this becomes a choice in almost 70% of our patients who need transplant. Other advantages are easy donor availability, multiple donor options. If even in a small families, if one child is affected, either the sibling will be half match, or or one of the parents will be half match. So you have 3 donors to choose with. So easy donor availability, multiple options, committed donors, short time possible, and donor can be approached for any post-transplant adoptive cell therapy manipulation. So these are the advantages because of which haploidentical transplants is now the preferred choice if we do not have a full match family donor. These are the various platforms by which haploidentical transplants can be done. So just to summarize, beautiful modalities are available to overcome the HLA disparity which is there in haploidentical transplants. Now coming to disease specific considerations. So we know that the 2 commonest diseases in our country, red cell disorders, not our country, across the globe, are thalassemia and sickle cell disease. So we can see almost 300 to 400,000 patients are born with sickle cell disease every year across the globe, and around 60,000 patients are born with thalassemia every year across the globe, out of which in India, if we talk about sickle cell disease, around 10% of the global population is born every year, 40,000 patients as per very rough estimates. When you talk about thalassemia, around 10,000 patients are born with thalassemia each in our country, despite taking so much of aggressive efforts to actually bring down both these diseases. So still a huge disease burden. When we talk about the clinical burden of the disease, thalassemia, we all know a lot of disease-related comorbidities, lot of treatment-related comorbidities, which we have to address while offering transplant for these patients. Sickle cell disease, a single base pair mutation actually leads to all this abnormal shape of red cells, which in turn cause 2 major clinical manifestations, either hemolytic manifestations or vaso-occlusive manifestations, and we know all the effects of either of these hemolytic manifestations or vaso-occlusive manifestations, which are the hallmark of sickle cell disease, the pain crisis or vaso-occlusive crisis. When we talk about the treatment approaches, so all the supportive care measures, I mean hydroxyurea, chronic blood transfusions, chelation. These are the supportive care measures. But awaiting a wider application of gene therapy, bone marrow transplant is the only feasible curative option at this point of time, and that's why we need to talk more about it. Does one size fit all? Can we use the same strategy for every patient? It doesn't happen. If I have a patient of 5 years undergoing a full match donor, the strategy will be different. If that patient is undergoing a haploidentical transplant, the strategy will be very, very different. So we have to modify our strategy based on the patient and the donor, and also based on what is the performance status of the patient. So what we have learned over a period of time, that we need to optimize the approaches. We can't just sort of directly translate whatever is being done in the West, and this is a small example of what we have done. So we have developed this protocol for sickle cell disease, which is now most widely used protocol for haploidentical transplants across the globe, and this is our initial publication with very, very encouraging results for in a very sort of severe symptomatic cohort of patients. This has been further extended, so it was in half mesh transplant. This has been further extended to full mesh transplant, just looking at the success of that particular protocol. And these, as you can see, excellent survival curves using this approach. Recently, just 10 days back, we got this publication in Hematologica, where we have showcased our outcomes of match sibling donor transplant for sickle cell disease. This is one of the largest cohort of match sibling donor sickle cell disease in the world, and just look at the outcomes. So overall survival is 96%, phenomenal outcomes. And I'm just reiterating it again, that the patients whom we see here is very different from the Western population, very, very symptomatic patients, and to give outcomes like this is actually very encouraging. Severe aplastic anemia, again a very significant disease. We have modified the strategy based on the need of our patients. So this is a novel strategy using thiatepa on the backbone of the routine conditioning, and you can see very, very encouraging results. This is again multicentric data, pan-India, of severe aplastic anemia haploidentical transplant over a period of 15 to 20 years. So because of the heterogeneity, you can see this difference in the survival curves. But more or less in today's day and age, the outcome of haploidentical transplant also in severe aplastic anemia is more than 90% if we get the patient at the right time. This is our paper on acute leukemia, so acute lymphoblastic leukemia and acute myeloid leukemia. Again, looking at the survival curves, transplant offers at least 20 to 30% of the survival advantage over conventional chemotherapy in both acute myeloid leukemia or acute lymphoblastic leukemia. So take home message, transplant is an integral part of hematology and oncology. The landscape of transplant has evolved over the past 2 to 3 decades. The donor choices have expanded, universal with the, as I said, donor availability is universal. Any patient who needs a transplant has a donor available nowadays. Safer conditioning, better GVHD prophylaxis regimens, better supportive care have led to improved outcomes of transplant. The transplants, however, needs to be optimized to meet the needs of various geographic locations. So as I said, we cannot do just whatever is happening in Europe or America and directly translate it to Indian practice. We have to modify based on the needs of our patients. A number of times transplant needs to be individualized. So if some patient is having a renal failure, we need to modify a strategy to meet that need. So we have come a long way in transplant, and but I'm sure that the future of bone marrow transplant and cell therapy, which Dr. Dinesh will be talking subsequently, is very, very, very bright in our country. So thank you for a patient listening, and I'm happy to take any questions.
or give a subcutaneous, and that works as an anti-cancer therapy. This is a CAR T cell, which is my topic. So what we are doing is you're taking your T cells and modifying it. We are putting some antibody portion there. There is an antibody portion. So this is a Fc domain of the antibody, which is on the cell surface of CAR T. It has many parts of it. So it has a Fc domain, it has a hinge, it has a transmembrane domain, and there is an intracellular domain. So by you take a virus vector, and that takes this antibody and put it to the T cell surface. There are many generations. The first one didn't work. There was no co-stimulatory domain. Now the most commonly used is a second generation, which has a red one, this co-stimulatory domain. Either you use a CD28 or 41BB. Then there is a third generation. Gaurav is producing. Gaurav is the owner of the company which is producing a third generation CAR T, which has a two co-stimulatory. I'm proud to say it will be the first one probably. We don't know whether someone else also has it, but the third generation bispecific we are making it in India. And then there is a fourth generation where you have a certain cytokine production which affects the cells, allows the cells to produce the cytokines. So there are many we have a CAR T, we have many generations of CAR T. So many of them are already approved, some of them are still in the trial. What are the differences between the CAR T cell and bispecific? So as he said, the CAR T is a living cell. You are taking the cells, making them to kill the cancer and put it back. Bispecific is kind of a protein drug. It's like an antibody. This is because it's autologous. It is a personalized. Every individual will have a separate, has to be made. This is off the shelf like any drug. There is a one antigen. There is an antigen and CD3. So there are two hinges. The CAR T is done only once. You don't have to do repeatedly. They persist in your body and they keep killing the cancer. As soon as the cancer tries to come up, they keep killing it. The bispecific works for only few days. So then you have to give it continuously. So there is more, keep giving it. Very high potency. The CAR T is more potent, probably the bispecific. There are certain side effects which are more common in CAR T versus in the bispecific. But both are attacking the T cells. How do you make the CAR Ts? Collect the patient's own white cells, isolate, then activate them. Then you engineer the T cell with the CAR T gene. So there is a viral vector which induces and then this antibody receptor is brought to the surface through the vector. Then you have this has 4 parts, and then you expand. Once you do this modification, then you expand the number of these the modified cells, and that becomes ready. You bring it back and use it as a autologous transplant. Like autologous transplant, we were using chemotherapy. Here you give condition the body and then give the modified T cells. This is another way to show you. There's the initial consult and apheresis. Then you give a bridging chemotherapy like to control the disease. It takes 3 to 4 weeks to make the CAR T. In between, the disease should not progress, so you can give a chemo or radiation between. Then you give a lymphodepletion, means you have to allow the body to accept these modified T cells. So you give a fludarabine and cyclophosphamide. Day 0, you do a CAR T cell infusion. And there are certain specific toxicities. So CRS is a cytokine release syndrome. ICANS, people who do a transplant, they know these kind of the side effects. ICANS is the neurological side effect, infections and cytopenias. So these are 4 major side effects of CAR T cell therapy. How it is important? Previously, if you see in myeloma, any single drug, if you take it before these immunotherapies, whether it is a bispecific or CAR Ts, they all were roughly around 30% effective. What these drugs have done, these are our own immunotherapies. They are not only the immunotherapies, they are not killing the cancer cell, not killing the normal cells. They are more effective than any other drugs. The others, if you see a 30%, they are more than 60% or more than 60% effective. So they are more targeted and they are more effective. Thus, we are going to the different era where there are more effective immunotherapies are available. This is one of the example of ALL. Whatever chemotherapy we were giving it, we were doing a MRD and they were MRD negative. Still the people were relapsing. The results were only 68%. They have given only one bispecific antibody, is called blinatumomab, and if you see a flat curve, the results are 85%, and that curve is not dropping. So the 85% of the people. So in spite giving all kind of chemotherapies, what we had a success into the pediatric ALL, still you can make a difference by giving a one bispecific antibody. So now it has become a standard of care, not only to give in the pediatric ALL, not only to give a chemotherapy, you have to use a bispecific therapy. Unfortunately, it is not available in India and is very costly. Otherwise, all the ALL patients from the infant ALL to the elderly ALL all need blinatumomab to improve the chances. The another example of this is a myeloma. Myeloma is an incurable disease. But this is a CAR-T for myeloma. This was used as a last resort when there was no other drug available. What they have shown, this curve has become flat. After 5 years, there are 33% of the patients who were completely refractory. They would have died within a few months. They have not only survived, it's only one infusion of the CAR-T. They not only survived, after 5 years, 33% of the patients, they are 10 raised to power minus 6 MRD negatives. Single infusion after 5 years, MRD negative to the depth. Now we are talking about the cure in myeloma. So probably these 33% of the patients who have received this CAR-T have been cured. So it's a one-time therapy, and there are certain and can we get there? Can we improve it? So now we are using CAR-T earlier in myeloma, whether we can improve the fraction of curative fraction. So giving a one therapy and maximum people can be cured. There will be some day. So previously we were not talking about the cure. We are talking about the, so this is a difference between if you use it late is a CARTITUDE-1 and CARTITUDE-4, it is a higher responses into the CARTITUDE-4 because it has been used in the first to 3 lines. And if you are a standard risk, if there are two types of myeloma, one is a high risk and the standard risk. And if you are a standard risk and if you use a high CAR-T upfront or early lines, you should see a more fraction of people have been cured. So the things are changing very fast. In ALL, if you are relapsed in diffuse large B, in lymphoma, diffuse large B cell lymphoma, if you are relapsed, the treatment option was autologous transplant, Gaurav's era, but we have done better on that. So there are 3 trials. One has failed because of some technical reasons, but the 2 trials have shown the results of autologous transplant was 20%, and now there are 40% of the patients are cured with the CAR-T cell. So if someone who has a DLBCL relapses, we directly go for the CAR-T cells, and which is better than the next available therapy. So this significant, if I would have not been in the field for 5 years, and if I come back to the field has completely changed because of these immunotherapies. So now, even if in the ALL, if you are a primary refractory, in DLBCL, if you are a primary refractory, directly go for the CAR-T cell. If you are transplant ineligible, directly go for the transplant, for the CAR-T cell. If you even go for the transplant, if you go for the salvage chemotherapy, no response, go for the CAR-T cell. If you have failed a transplant, again you go for the CAR-T cell. So 1, 2, 3, and 4 times, at every part of the spectrum of the treatment, you can be eligible for CAR-T cell therapy. The CAR-T cell may be upfront for high-risk patients in myeloma and lymphoma in one day, considering the high potency of these responses. This is not only the DLBCL, there are different kind of lymphomas where there are much better results with the CAR-T cell therapy. If you see prior to the 2015, all drugs in the myeloma were not immunotherapies. They were drugs, the chemotherapies, but not the immunotherapy. Once you see after the 15, daratumumab, blinatumomab, they all are immunotherapy. So there is no chemotherapy has been approved from 2015 to 2016. They all are CAR-T cell, antibody drug conjugates and bispecific antibodies. Nothing comes free. They all come with the toxicity. These toxicities are different from the chemotherapies. So acute toxicities is a cytokine release syndrome, ICANS, cytopenias, as I said, infections, and they come at the different time points. So the toxicity for each product is different. It comes at the different timing, and the frequency also is a different. Late toxicity, there are some late toxicities because we are killing the B cells. Some of the normal B cells also have that antigen, so you will have a B cell aplasia for some time, and there are some long-term toxicities has been described. So people have to be monitored for long-term toxicity. This is the CRS where you have a fever, hypotension, hypoxia, and that needs a specific treatment with the tocilizumab. Then this is a ICANS, which is a neurological symptom. So you can have a headache to the coma, and that also requires a specific treatment for this. And now there are wearables. Sooner we'll have a wearables. Wearables are going to tell you the patient is going to get the CRS. So now the trials are going on. You can identify. So patient can be at home, and if he has some indication on CRS, he can come back and have been received. So this is a CRS with the different products, different frequency in the different diseases. The same product in the different diseases can have the different risk of CRS. ICANS also, the different products, different diseases, different frequency of this thing. And these are the late effects at the different time points. So you can have some late effects, though are very infrequent, can have it for the longer period of time. What do you need to consider? What are the logistics? What is the closest treatment center? What CAR-T products has to be offered? Can the patient travel or remain inside, whether it requires inpatient or for a longer duration? The patient, the most important thing in the cost, does the patient has the ability to pay the treatment, or when is the optimal time? When do you harvest the cells and when do you infuse the cells? So there are many things needs to be considered when you take it for the CAR-T cell. Not, as I said, some results are 40%, some results are 60%. Not everyone is responding to the responding and relapsing. So there are certain resistance of mechanism has been shown. One is related to the CAR-T, one is related to the cancer, one is related to the cancer microenvironment. I'm not going to the details of these things. These are the comparison of all three options: antibody drug conjugate, CAR-T cell, and bispecific. Everyone has some advantage and disadvantage. So one antigen, we have 3 products, and they can be used at the different time points. So that in fact gives us some cost advantage also. If there may be some competitions, and then that will be advantageous for reducing the cost. And then all have a different side effects and the different outcomes. This is now, as I said, there are dual CAR-Ts. So Gaurav is going to make a CD19 and CD20 CAR-T cell. There are some trials which recently, in a recent EHA, they are showing the only CD19 was 40% effective. This is 80% effective. So the early indications are, if you are at two antigens, it is more effective. I'm talking about the future. Whether we can have allogenic. Autologous takes time to take out the cells and make them. Allogenic, you make a universal CAR, give it to everyone like a drug. Whether we can make an allogenic CAR. Different antigens, one cell can have a different antigens can be targeted simultaneously, and we can make a multiple CARs. Not only the hematological malignancies, you can target the solid tumors, though there is not much success now, but future is all the probably solid tumors will be treated with the immunotherapy. This was why the people are not referred for the CAR-T, why we are not doing the CAR-T still in the some parts of the country. There was some from the hematologist response was taken, some questions were asked. Some people say looks like it is very cumbersome, some say it's too costly, some people think it may not be that much effective, it will be toxic. There are various things. So I think we can do a CAR-T. I think one you have done it, or probably someone has done a CAR-T in Gwalior, or no? So I think we should do it in Gwalior. Why we should not be doing the CAR-T? You have given a bispecific. So the bispecifics have been used in Delhi. So the antibodies are here, all the immunotherapies are available in India, and that is usable in even smaller cities, not in the big towns. It can be, with the experience, can be used in this. We have to remove the hurdles of. It is costly. We have to make it available to all. We need to go a long way. With this, I'll stop, and thank you. I have left 1 minute for questions. Thank you, sir. Mike.
I think one of my patients referred to your institute is on immunotherapy. The same CAR-T therapy, or we were talking Hardik?
Huh?
Hardik, 6-year-old ALL.
I think Dr. Gauri must be doing it, probably CAR-T.
Yes. Another question may not be.
We have a pediatric CAR-T available on trial also, so okay. I'm just telling.
So another question, certain Russian scientists are talking of cancer vaccine that is tailor-made, different for every individual. So anything
Vaccines will come one day, but I don't know whether Russia has a capability of doing it. I mean, we haven't heard after that. I mean, it was a, we need to wait. I mean, unless it has been used in the phase 1 trial, has not been presented into the any of the ethical conferences. So we have to wait. Either it should be published in any GM or presented in the any important meetings. We have to take it with a pinch of salt. I mean, if it is authentic, then it has to be presented somewhere which is a credible place. I think one day we'll have a vaccine. I mean, sooner or later we'll have a vaccine. It's just a same mechanism telling the T cells to kill the cancer.
Any other question?
Thank you.
Thank you, sir. It was a wonderful lecture. So please, you have to wait for the photograph. I'll request Dr. Gaurav also please join us on stage. Yes, sir. Dr. Anil and Dr. Vijay.
Now I would like to call chairpersons of another session, Dr. Gaurav Kharia sir, Dr. Akshay Kumar Nigam sir, Dr. Akshay Lahoti sir, Dr. Priyanka Bansal ma'am and Dr. Vijay Chaudhary sir. Dr. Anil Sharma sir.
Thank you. Now I invite Dr. Deepak Gupta sir, who is presently working as a senior consultant Medanta Cancer Institute, Gurgaon, and sir is awarded many awards and publication in national and international journals. Thank you, sir.
So, good evening all of you. I think all of you have listened such an important talk. Last two talks are like an eye-opener. So, as a radiation oncologist, before I start, I'd like to thank Dr. B.R. Srivastava sir and Dr. Gunjan for inviting me here. So, radiation has I will be talking about radiation in pediatric malignancy, but as a radiation oncologist, people have listened more of bad effect of radiation rather than the benefit of radiation, which we have been seeing for the past 100 years. So, past more than 100 years, radiation has a history. Once the X-ray was discovered 1895, then there is subsequent drastic change and evolution. As you have seen in the hematology, there has been drastic improvement. The radiation has also passed through many advancements. From a large field radiation, we are just nowadays trying to give a just pinpoint radiation where the tumor is moving. So how the radiation has changed over a period of time, this is an important figure in which I can try to explain. So probably 20 to 30 years back, if you see, if we try to give radiation to any patients, if we want to cure a patient, we need to give a certain amount of dose, but to give that dose, we have to give just an open field, so that whatever comes in the path of radiation, the normal tissue, take the same amount of radiation, what is actually needed for curing the tumor. So with the advent of MLCs, 3D conformal treatment, we just are able to able to reduce the dose to the target, but we are able to reduce the dose to the critical area. The advancement like MLC, the modulation and everything has changed the way we deliver the radiation. Not only this, but over the period of time, we also learned that there are certain critical structures which need some amount of radiation. There are other which can tolerate a little bit higher radiation. So if you can see on the left side, there are carotids. This is a laryngeal case. So carotids need some amount of radiation, less amount of radiation. If you are able to spare, you can reduce the risk of stroke, because these are early laryngeal cancer. They are going to live for 10, 15, 20 years once they are cured for the cancer. But not only the carotid, there is a constrictor which is just behind the larynx. So we understand over a period of time, if we are able to reduce the dose to this this critical structure, we will able to reduce the risk of aspiration to this. So we are, with the help of modulation technique, we are able to reduce the dose to this critical structure. And also with the biology, we understand if we limit our volume from the large field to the area where the tumor is failing, so we restrict our doses to single cord. So we are able to reduce the dose to the contralateral larynx and upper and lower, so that the voice changes, the edema goes down, so the quality of life improves. So radiation, which is a large field radiation, firing everything from a weak, has now become very strong, and it becomes so conformal, so tracking, such we are just treating the tumor with the area of risk. So we are able to reduce the side effect. So especially for pediatric tumor, the important, what we have discussed in the last few lectures, that it is not only important the cure, but it is also important because these are the children who are going to live another 10, 20, 30 years. So the quality of life is also important. So as a radiation oncologist, we normally play between these two sigmoid curves. One red curve is what we need to cure the tumor, and on the left hand side you see there is green curve, in which if you exceed that curve, there is a high risk of toxicity. So the area between these two curves, where every radiation oncologist try to give a dose so that we achieve cure along with less toxicity, better quality of life. We have the different kind of machine technology which has come up, which helps to improve the outcome. And also on the left side you can see the curve of protons, how the protons act. Normally if you see for any linac, you give a dose, there is peak, then there is a fall off, so there is an exit dose. But for the protons, the radiation beams goes and it stops there itself, so there is no exit dose. So we are able to reduce the dose to the critical structure to large extent. So how radiation is differed for children as compared to adult? We know the children, most of the malignancy are embryonal origin, and there is high heterogeneity. So we have already discussed in the last 2-3, like you see the round blue cell tumors. So there are different type of heterogeneity within the malignancy. There are different type of mutations which we got to know over a period of time. And also what happened, the tumor in children is mostly genetic. These are the chances of having environmental cause like tobacco, pollution, so and so forth is not there. But in adult, you are having, these are the factors which are responsible for cancer. And most important thing, once we are dealing with the children, we are not only dealing with the tumor which is proliferating, we are also dealing with the surrounding tissue which is also growing. These are, in the adult they are mature tissue, but in the children they are growing. So if you give the radiation, there are chances the growth of this tissue goes down. So this is epidemiology. I will skip this. So what happened in last 50 years, if you see the data, from 1970 to 2010 or 20, the survival of pediatric malignancy, which is close to 40% at 5 years, now has increased to more than 80 to 85%. This is because of the better diagnosis, better understanding of tumor, better radiation, better surgery, and lot of advancement like chemotherapy, immunotherapy, stem cell transplant, and CAR T cell therapy. So per se for indication, the standard indication like you give radiation before chemo, after chemo, with chemo, and in children we are along with the adult, we are also using certain fields like in medulloblastoma, like large field radiation, treating the brain as well as the spine. Total body radiation, which is helpful for the stem cell transplant. So these are the few other conditions in which we are using the radiation. If you talk about 20 to 30 years back, radiation is required in almost 70% of the pediatric malignancy. But with the advancement of better chemotherapy, better tolerated drug, and everything, the chances of using radiation for pediatric malignancy has gone down to almost 30 to 40%. These are the common indication. At some point of time, you do need radiation in this group of tumors. A little bit about 2-3 malignancy. So for ALL, when you are treating the ALL in 1970, 60, there are 80% or 80 or 90% of patients who do fail in the brain. Initially, they started using craniospinal radiation, but CSI is associated with toxicity. But with a better use of intrathecal methotrexate, other therapies, now the radiation has been reduced to cranial radiation, and we are also able to reduce the dose from 24 gray to 12 gray. So we are able to preserve more of the neurocognition as what we are able to preserve previously. In terms of medulloblastoma, the chances of cure almost 60 years back is less than 10% when you are not using the CSI. But CSI has changed the management of entire medulloblastoma. And the chances of control rate with using the CSI alone, not with the chemotherapy, is gone to almost 50 to 60%. But with the use of better chemotherapy, better scheduling, we are able to reduce not only the dose of CSI from 36 to 26, so that we better preserve the neurocognition, better preserve the bone marrow. We are also able to optimize the treatment, and outcome has increased to 80 to 90%. And also with the molecular classification, especially for medulloblastoma, we are able to classify which are good risk, which are standard risk, which are high risk, which are very high risk. So we are able to optimize our treatment and give the treatment accordingly. In terms of Hodgkin lymphoma, radiation, the role of radiation although has reduced, but the understanding of treatment has changed a lot. If you see, initially when a radiation oncologist used to give radiation in lymphoma, we used to treat the neck, chest, everything, give a mental cell treatment, large field radiation. But with the more understanding, better chemotherapy, we are able to reduce to volume from the large volume to just where the tumor is involved. Nowadays we are just treating where the involved nodal site or where is the residual disease. So from the large field, we have just reduced a small field. So we are able to reduce the toxicity, and not only reduce the toxicity, but the risk of second malignancy, which people most fear of because of radiation. Neuroblastoma, there is a role of radiation. I'll not go into the detail. So these are the common indication in which we use radiation, especially for the pediatric. But the most important thing, as a radiation oncologist, normally we give 2 gray per fraction if you are treating the adult, but in pediatric, we normally use 1.6 to 1.8 gray per fraction. So we reduce a dose per fraction a little bit, so that we reduce the side effect, we reduce our volume, so that less of the dose goes to the critical structure, and we are able to reduce a lot of toxicity, which was previously thought a lot of toxicity is there. So what happens if I have to treat especially a pediatric case? So the most important thing, we as a radiation oncologist, we need a person, our children has to be lie down in a same position, so that what we have planned should be delivered precisely. And for this, we need extensive pre-treatment counseling, demonstration to the children, so that it understand what we are going to do, how we are going to do, and it cooperates. Sometimes if the children does not cooperate, mostly it happens less than 5 years, 6, we need to give general anesthesia or a sedation, so that we make him comfortable. These are the common steps which we follow in radiation, like immobilization. This is the first and the most important steps as far as radiation oncology, because if the child is stable, lie down in the same position, treatment can be delivered safely. And after this, we do a CT scan, we do MRI, we do PET and fuse, delineate the target, we do the plan, we use the best possible way to reduce the dose to the critical structure, and we look at the dose to the critical structure as low as possible in pediatric. Then we do quality assurance for all the patients before we deliver the treatment after verification. So especially for children, where there are certain other challenges which normally we do not see in an adult patient, like if you are treating a craniospinal irradiation, it is a large field like craniospinal radiation, and also a total body radiation in which you are going to treat the entire body. So any machines you use other than tomotherapy, the field size is 40 centimeter. You need to make junctions, and matching a junction itself is a problem, and treatment time is so prolonged that you need anesthesia, especially for children. But with the advent of technology like tomotherapy, you just take a scan, and if the child is less than 135 centimeter, it can be treated in a single go. There is no need of junction and anything. And if the child is more than 135, then you need a head first and feet first supine and make a single plan, and it can be delivered easily without moving a patient, but only you have to rotate a patient once and the treatment can be delivered. So this is how the technology helps in treating such kind of treatment. Another important, the most important thing which we are normally as a radiation oncologist does not think while we are delineating the target, because the children is actually a growing child. The bones are growing, the marrow is growing. So if you have to treat a children who is at a growing age, below puberty, less than a puberty, then if you need to treat a vertebra, probably a neuroblastoma, craniospinal radiation, if you try to treat partial of the vertebra, there will be a skyphosis, lordosis, the growth retardation. If you are treating a pediatric, please keep in mind you need to take entire vertebra while you are treating a pediatric patient. So the risk of growth retardation can be mitigated. So side effects are there, but they are normally during the radiation, because radiation, chemo gives through the blood and goes through the entire body, but the side effect of radiation is to that area where we are giving the radiation. So side effects, acute side effects, yes, are there, but still manageable. But for pediatric case, we need to remember that this is a fragile organ system, growing organ system, and there's an incomplete immune development. So these need to be taken care in mind before we plan a children. So utmost care has to be taken. So the acute effects are quite manageable, common, which happen in adult also, but the late effect, which is more important and more mostly to be looked for. There is some the toxicity of radiation is related to the part which we are treating, and there is some dose response relationship. So if you are using a higher dose, there is a high probability that you will get more of a side effect, particularly in the surrounding area which is close to the area which we are treating. And how they are related, so the side effect related to the organ which you are treating or a structure, and at what age you are treating. We'll discuss in the subsequent slide what volume you are irradiating, what additional chemotherapy, neoadjuvant, concurrent you are using. So all the side effects are depending on these three important factors. So for children, because the tolerances are different, there are certain side effects which are different, so that defined guidelines how to see the structure of a normal tissue structure for children. This is defined as PENTEC, and recently it has been published in 2023. So in children, there are four different growth pattern. I'll not go into the detail, but the important point is, if a children is less than 5 years, you are treating the brain, there is high risk of IQ loss, means cognition. And if you are treating the spine before puberty, there is a height loss. For pelvic radiation, you are giving, there is risk of ovarian failure if you treat at the age of adolescence. For chest RT, at the time of menarche, there might be a risk of breast hypoplasia. So what does it say actually? It says that you use same dose at a different age group, and you are going to see a different side effects. So that needs to be remembered while you are treating a patient, at which age you are treating, what dose you are giving. This is the most important. And I'll not go into the detail of all the side effects, but what is important, there are some side effects which are similar to adult, but there are unique side effects which you are seeing only in children, not into the adult, like musculoskeletal growth, because these are growing muscles, growing bone. There is spinal scoliosis. If you are treating a nasopharyngeal, there might be a dental developmental process delay. There's a breast hypoplasia, reproduction organ maturation. So there are dose constraint which has been defined for this dose constraint you will not see for older adult, which is more than 18 years, because they are not relevant for the adult. So the important part, the second cancer which has been most talked about for a radiation, if a person going to live 5 years, 10 years, and is going to ask, the important thing, if any patient has taken any kind of radiation, there is no dose response relationship. There is no true safe threshold. So if a person is getting 10 gray, 20 gray, it is not necessary that person getting 10 gray will not get setting malignancy, 20 gray will get. Everybody has a different chances of getting setting malignancy. And what is important, so if a person is getting 10 gray, another is getting 20 gray, the risk of malignancy is not going to be doubled with doubling the dose. So there is no linear relationship. So it is difficult to predict that somebody will going to get a second malignancy, somebody is not going to get the second malignancy. And the most important thing, the risk of second malignancy, which has been reported till date in the literature, if you search the entire literature, in a pediatric population is close to 70 to 90%. Probably it is because of lifestyle, genetic, treatment modality. And importantly, the radiation constitute only 5%. So the radiation has been much talked about that radiation will cause second malignancy, but radiation is constitute only 25 to 30% of the cases. And as I already told you that the role of radiation in pediatric malignancy has been decreased by almost 50% in last 10 to 20 years. And if you see that SEER database, in the last 2 decades or 3 decades, the risk of second malignancy has been almost double. Means it's not the radiation which is culprit, there are other factors which is causing it. Yes, we have protons which can reduce the dose, which can reduce the risk of second malignancy, and the most important, this risk of second malignancy is not going to reduce over a period of time. There is certain risk which is there. So how we can reduce this risk of second malignancy or any other side effect? We use normally a risk adapted strategy, like we lower our doses, lower our volume, omit radiation, we use smaller target volume, we use best possible technique like breath hold if you are treating the breast, and protons, so on and so forth. And especially for children less than 3 years, which are more susceptible, we try to delay the radiation as much as possible, so to reduce the side effect. And on the other hand, if the tumor is favorable, we try to reduce our dose. If it is unfavorable, we try to escalate our doses. And in the last, follow-up is important, not only to detect early recurrences so that it can be salvaged, but the most important part in pediatric is the late side effect. And whatever you are treating, you need to understand what kind of side effect they are going to happen. Suppose if you are treating a brain close to pituitary, you need to follow up with the endocrine. If you are close to eye, you need to follow with the ophthalmology. So for pediatric especially, you need not only a pediatric oncologist or a radiation oncologist, you need neurology, ophthalmology, a complete team is needed who can look into this side effect and can detect early and can be, overcome early. So treating a pediatric is not only single specialty work, it has to be a complete plethora of specialty which needed to optimally treat, so that the outcome which has been reported in literature close to 80 to 85% can be achieved. And as a dictum in our hospital, every patient of the pediatric should go through multidisciplinary tumor board. So suppose if a facility is not there in the hospital, you should discuss the case with the facility where is available, so that we give the best possible of the treatment and the best possible of the outcome. So to conclude, radiation is a vital important, and there is a pillar of oncology, and there is a fine balance between the cure and late effect, and we have to play between that so that we optimize our treatment, we reduce our side effect and improve the control rate. And importantly, the survivorship is important for pediatric. And in terms of radiation oncology, if you talk about, now we are moving toward the era of flash radiotherapy, in which we deliver very high dose of radiation in a fraction of second, and use of AI and genomics might change what we are treating today, might be changed in the future, because the AI will give you more insight of the tumor. So with this is my team. With this, I like to thank you. Any questions?
For imbalance. So oral salt tablet, normal salines, and if you use severe hyponatremia, then use a 3% sodium also. And tumor lysis syndrome is the most common in the leukemic patients. Very high TLC count, come in the emergency first time, and patient in the land up with the TLC is 2 lakhs, and we are the last tumor cell destroyed. So rapidly an intracellular component is released into the bloodstream, so leading to the tetrads. So hyperkalemia, hyperuricemia, hypocalcemia, and hyperphosphatemia. So these all are the findings are the tumor lysis syndrome, and treat with the fast. So how to assess the clinical manifestations? So hypocalcemia, we are already discussed. Hyperkalemia, so symptomatic is generalized fatigue hoga, and then do the ECG and abnormality in the ECG. And hyperphosphatemia, cardiac rhythm is disturbance, and hyperphosphatemia is creatinine is very high, decrease urine output. So treat with the good hydration, add the sodium bicarbonate. If your uric acid is very high, then use the rasburicase, and administration is the aluminum hydroxide. Assess the urine pH, and administration the allopurinol also. So these are the clinical manifestation, symptoms: non-specific nausea, vomiting, weakness, malaise, neuromuscular irritability, arrhythmias, seizure, and routine uric acid and electrolyte measurement are the indicator to find out the cardinal biochemical features. So this is are the only routine tests during the TLS. So management: IV hydration 3 to 4 liter per 24 hour with the sodium bicarbonate, and do the allopurinol use the prophylactic. If or the very high uricemia like 12, 13, then you use the resbiricus. So you do the before G6PD when you give resbiricus. This is very important. So otherwise is a hemolysis, and the dialysis in case of the refractory hyperkalemia and severe acute renal failure. And next is the hemorrhagic cystitis. So hemorrhagic cystitis also in management, the sometimes the cervical cancer by the external pelvic radiation, brachytherapy may cause the hemorrhagic cystitis. And also observe in the patient high cyclophosphamide, ifosfamide drug in the long period, then patient complication is the hemorrhagic cystitis. So dysuria, frequency, urgency, burning sensation, gross hematuria, incontinence, these all are the hemorrhagic cystitis. So management: oral IV hydration and mesna. So every time when you use more than 1000 cyclophosphamide, so use with the use drug with the mesna. So acrolein is the toxic released by the cyclophosphamide. So mesna is detoxify the acrolein, its metabolite in the urine. And internally kill ligation or embolization, urinary diversion, and cystectomy when you use the aggressive gross hematuria. So sometimes the leukemia. So most of the hematology ward, most of the patient is the ALL, AML, pediatric ALL, AML. Every patient during the treatment land up in the neutropenia. So this is very important in the how to treat with neutropenia. Not all time in the doctor in the ward. So staff, nurses on duty attending the patient. So hand wash, and again hand wash. So when you patient touch, you just do with the hand wash with the success step. So not do the like patient को touch किया, another patient touch किया, नहीं, just do take the hand wash again and again because of the barrier of the next cross infection. So how to assess? So ANC is less than 500, and ANC that is expected to decrease to less than 500 cell during the next 42 hours. Profound is sometimes used to describe neutropenia if ANC is less than 100 is a severe neutropenia. So these are the classification of neutropenia on the basis of the severity, duration, acute, chronic, less than 3 months is acute, more than 3 months is chronic, congenitals, mechanical decreased production, increased production. So these are the classification of the neutropenia. So neutropenia is a medical emergency. Timely intervention save the life. Otherwise, this is very dangerous. Patient goes on the septic shock. So this is a cause: gram positive, Staph aureus, Staphylococci, Staphylococci, and gram negative is E. coli, Klebsiella, and Pseudomonas. So risk factor is the IV device, most of the PICC lines, most of the central line. So when you patient having febrile neutropenia, patient having the fever, just do the blood culture, both central line and peripheral blood culture. So assess the infection because of the catheter related or the peripheral blood. So this is a diagnosis, history, and examination. And management is the start with the early antibiotic and send the culture and just wait for the culture and vital monitoring. So this is my take home message: early recognition save lives. Most oncological emergency are the reversible. So team-based care is essential, and protocol are preparedness is improve the outcome. So this is very important: team-based work in emergency. Thank you.
Hello. Any questions or comment? So thank you, Dr. Ashok, for a nice lecture. So next, I would like to invite Dr. Amardeep Pathak. He is head and consultant and head of transfusion medicine at Rajiv Gandhi Cancer Institute, and he has many awards to his name. Over to you, Dr. Amardeep.
Machine just collect the desired component from the donor, and rest of the component return back to the donor. Okay, so basically if I'm collecting plasma, it's a plasmapheresis. If I'm collecting platelets, platelet pheresis, RBC, erythrophoresis. And if I'm collecting granulocytes, it's for granulocyte harvest, it's a granulocyte pheresis. Apart from normal collection for the transfusion, we can treat the patient also with the apheresis. It's known as therapeutic apheresis. Therapeutic apheresis with the aim of to removal of the pathogenic molecules with the goals of substance removal, deficient substance replacement, modified the disease, and collection of the autologous cells for the transplantation. Okay. So they may be adjunct to the chemotherapy or immunotherapy, but they are really a safe procedures, but cost is the limitation. So we can divide apheresis into two, the normal therapeutic for plasma exchange, therapeutic leukocytopheresis like AML cases, thrombotic thrombocytopheresis, electropheresis, electrophotopheresis, and immunoabsorption. Non-therapeutic, single donor platelet, single donor plasma, single donor RBCs, stem cell collection, like I'm talking about in detail in subsequent slides, donor lymphocyte harvest, DLI or CAR-T collection, and donor granulocyte collection. The sources are the bone marrow, peripheral blood stem cell, and cord blood. These are the main three sources. I'm discussing about the peripheral blood stem cell collection because it's the most common source of collection nowadays in our setup, because we can collect a higher dose and it's gives a faster engraftment to the patient. Indication wise, these are the most common indication in autologous and allogenic transplantation. Autologous and multiple myeloma, lymphoma, and selected autoimmune disorders. Allogenic, acute leukemia, aplastic anemia, thalassemia major, MDS, and congenital immunodeficiency disorders. So HSCT is a curative therapy for all malignancy and non-malignancy cases. So efficient, safe, and quality assured stem cell collection services of blood centers are very crucial for any BMT services or the transplantation. So our role is apheresis physician or clinical consultant for the transfusion protocol designing, troubleshooting the refractoriness after that BMT, managing the transfusion reactions, quality and regulatory or donor advocate safety manager, because see, blood bank comes under the drug and controlled licensing. So the Gazette of India advocates the criteria for the donor, the criteria for the procedures, and criteria for the every kind of investigation on the blood bank. So we have to follow the each and every criteria as stated in the Gazette of India. And of course, we are the bridge between the clinicians, laboratory, and the donor. By the department or per se the department, we manage the patient pre-collection, during the collection, and the post-collection phase. In pre-collection, we evaluate the donor as per the criteria, whether it's the donor or the patient. When venous assessment is very crucial, because if veins are okay, we will go with the periphery. If veins are not okay, we'll go with the central line. Consent and counseling is very crucial. Then comes with the laboratory investigation for TTI screening and CBC, biochemical, and other immunohematological workup. During the collection, machine selection is very important. I will come in the next slide for the detail of the device selection. Anticoagulant, this is the main crucial component for the procedure and the adverse donor reaction management also. And the collection optimization in the terms of, see, these machines are all automated. We have to just monitor the flow and the color of the product what we are collecting, and the manipulation during the time. We have to do some manipulation during the collection. Post collection, CD34 enumeration. Yes, what kind of number of dose we have collected. Product processing in the terms of the cryopreservation of storage, labeling, and the release at the time of transfusion. It's just like a normal transfusion after the collection. This is the checklist for the clinical transplant department. So each and every request comes with the checklist and the request from the clinician for the particular patient. Coming to mobilization, there are main three strategy for the mobilization. GCSF mobilization is very common approach. Chemomobilization is in selected cases. Plerixafor is for the main for the poor predictor or poor mobilizer, and as a rescue mobilization. So how can we identify as a poor predictor? That patient has a prior chemotherapy or radiotherapy, advanced age, extensive marrow involvement is there, previous lenalidomide exposure is there, low platelet count or prior transplantation. So generally mobilization done for 4 to 5 days. 4th night we do a pre-CD34 count. If less than 10 per microliter, we go for the plerixafor, and 5th day morning we collect the stem cell for the autologous transplantation. So all instrument what we are having in our transfusion medicine department are based on centrifugation, whether component preparation with the whole blood collection or apheresis, all based on centrifugation. They have own specific tubing, disposable set, and that unique to that instrument also, because there are different types of instrument based on intermittent and continue. They have low extracorporeal volume, means machine कितना donor से collect कर रही है और कितना अपने machine में अंदर रख रही है, because important for the pediatric population. Anticoagulant generally used, we use acid citrate dextrose. Venous peripheral is preferred. We do 90% in allogenic cases in our center. Central mainly in autologous and in pediatric population. Adverse reaction most commonly citrate toxicity depicted by perioral tingling, tetany, chills. Generally in protocol, every therapeutic procedure in our center, we continuously infuse the calcium, 10 ml gluconate and 100 ml for the whole 6 hours slow infusion. And next is vascular hematoma and vasovagal type of reaction. These are the devices which generally used in transfusion medicine department. So intermittent type, hemonetics, MCS kind of machine, they are generally old types of machines, hemonetics type or intermittent. They are having a large extracorporeal volume, so they are generally not safe. And the continuous type are listed below: Kobe Spectre, Trimicell, Optia, Amicus, Comtech. They are single needle machines having less extracorporeal volume and suited for the pediatric population. So we have 4 Optia with us, 2 Amicus and 4 Trimicell. So we have 12 machines with our institute. All are continuous type of centrifugation machines. So in nutshell, for the collection of stem cell in transfusion medicine department, patient donor documentation identification is there, consent verification is there, CBC and laboratory investigation done, machine setup and priming is done, vascular access peripheral or central is done, collection is start, monitoring and adverse donor reaction, product labeling and their processing, and post-procedural means if go to direct transfusion or for the cryopreservation and storage. Coming to storage, enumeration CD34 is there. For autologous collection, minimum 2 into 10 to the power 6 cell is required. Optimal dose is 4 to 6 and 10 to the power 6. Allogenic, minimum 3 is required, and optimal is 5 to 8 into 10 to the power 6. Higher the dose, higher the engraftment. Cryopreservation generally done for the longer storage for 6 months or 1 year of storage. Cryoprotectant we use generally 5 to 10% DMSO for the with aluminum, HES, attached starch or plasma light. Storage generally done for cryopreservation in -196 in liquid nitrogen control rate freezing or -80 dump freezing. Basically liquid nitrogen control rate freezing is superior than the dump freezing in -80. And adverse effect of DMSO is nausea, bradycardia, hypotension and garlic order. Each and every product we manufacturing blood bank or collecting through the apheresis procedure, we have to do QC. Without QC, it is no value. So for the PBSC, the CD34 count 2 into 2 to 5 10 to the power 6 is there. Total nucleated count 2 to 5 10 to the power 8 is there. Viability at the time of collection 90% should be there. Post-thaw at the time of transfusion more than 75% should be there. They should be sterile, free from the viral infections. Product volume, labeling, is very critical, and collection efficiency generally monitored through the quality assurance and the procedural environment, whether the procedure is going good or not. Donor safety, see, regulatory standard and donor safety is critical to blood bank because it comes under the regulatory drug and control requirements. So every donor has to be informed, and informed consent should be taken. Confidentiality has to be maintained. Counseling for the risk and benefit assessment should be there. Follow-up should be there. Unrelated transplantation, the registry protocol, the transport regulation, and the ID compliances should be followed. Regulatory standard in our India, DGHS, NACO, and the NABH is crucial. Internationally, AABB and International Society of Blood Transfusion should be there. But the key essential requirement is SOP should be there, traceability, staff training competency, temperature monitoring, and incident reporting should be followed. Challenges, yes, this procedure or the collection of the therapeutic with every kind of procedure is costly. Training is limited. Cryopreservation device and Plexa for accessibility is limited. The solution is we have to have a regional center with a collaborative network. Training and standard SOP should be there and should be distributed equally among us. Emerging trends and future direction. Now we are expanding our role from stem cell collection to CAR T collection, which we are doing in our center. Dendritic cell, NK cell, mission cell therapy are the expanding transfusion medicine scope, and gene therapy platforms should be explored. Future direction, AI-assisted collection prediction is there. Automated cell processing instruments are available in the centers. Point of care CD34 monitoring should be done. Safer cryoprotectant should be used. Gene-edited stem cell and personalized cellular therapy, like Dr. Burhani was telling in their lecture, are the future. So key take-home messages are PBSC collection is a big backbone for any kind of transplantation, whether it is autologous or allogenic. Transfusion medicine is the central to safe and effective collection. It is the, again, backbone for the PBSC HSCT. Donor safety, quality assurance, and compliances are very critical. CD34 monitoring, optimized mobilization improves the outcome. Cellular therapy is expanding beyond the traditional transplantation like CAR T therapy and other kind of therapies. In our department, transfusion medicine, in general, monthly we are collecting 1200 whole blood and collecting 300 pheresis per month. Almost 10 SDP collection in a day, 20 PBSC collection monthly, 2 DLI per month, 2 CAR T per month, 50 granulocyte harvest with the apheresis machine, which we are having in our center, 100% leukodepleted products and 100% irradiated product with RFID tagging, 100% plated additive solution for the 300 apheresis we are collecting there, and 100% ABO and RHKL type means 8 antigen typing cross-match blood for the patient 100%. Means we are typing 100% donor and 100% patient. When we matching the profile, then only we are issuing the blood to the patient. These are my references, and thank you. Any question? I'm happy to.
I have 3 specific questions to Sir, this side. You're junior. Sir is my MBBS senior also, so I have all the right to ask the questions. So I have 3 specific questions. Number 1, are you doing a mid-collect CD34 or not?
When the clinician demand higher dose,
then only.
Then only. Or I'm giving the product for the CAR T or for the any kind of special procedure like CD34 enrichment or T alpha beta depletion.
Otherwise,
kind of
in routine
otherwise, in routine we are doing only CBC. So I'm
assuming on the basis of TLC that it will give.
No. Generally, in my experience of last 10 years in our center, for allogenic collection on the basis of donor weight and age, I'm calculating the dose and the volume on basis of TLC only. ml more with
The cutoff.
the collection autologous.
So how much maximum we can collect? This is the question number
As per the drug and cosmetic guidelines, 45 kg donor say we can collect 350 ml, and 450 ml we can collect from more than 55 kg this thing. So this not applied to the patient per se. I'm talking about donor. So I'm collecting more than 300 and 350 between volume collection for autologous for the patient, and strictly following for the donor and allogenic.
And the third question is, I have collected the product. How many days I can keep it at 2 to 6 degree?
Okay, so you can keep the product up to 72 hours at 4 degrees centigrade in your blood bank.
This
Not more than that.
We are starting our services also, so I need to be very
no. So up to 72 hours you can keep the product at 4 degrees centigrade with strict monitoring.
Okay.
Yes.
Thank you, sir. Thank you, sir.
Usually my question ki how long if you administer the Plexafare, so in your practice what time collection of stem cell in duration? If you administer the Plexafare, so how many? Yes, Plexafare. So how many durations you start the collection?
So generally mobilization done for 4 to 5 days. Fourth day night we generally do PD-CD34 for the autologous collection. If the count is less than 10 per microliter, we give the Plexafare 12 hour post the collection. So
previous night at 9 a.m. 9 p.m.
So
in night
I'm collecting the stem cell
at 9 a.m.
9 morning. So the
9 p.m.
the
you give.
Plexa 9 p.m.
9
yeah.
p.m.
So 10 to 12 hours is the same like you were talking about febrile neutropenia is there.
And you are still giving morning GCSF dose at 4 a.m.
Yes. It is there. Yeah. Mobilization protocol is not differing. Plexafare is the extra you are giving to the patient. And like 5-day mobilization for the stem cell collection. For the granulocyte, for the neutropenic patient less than 500, the single filgrastim dose 10 to 12 hours before in the morning is sufficient for the collection for the neutropenic patients.
Can I add to this point? Because I have worked extensively in Plexafare thing. Because we are using Plexafare for each and every patient. And I have seen the result from my last 10 collection. We are also doing backup collection as we are getting more and more. So what I am following is, I see the peak is at 6 hours. If you read the Plexafare pharmacology.
But ma'am, is it approved for allogenic transplant?
Yeah, Plexafare.
No,
it is for backup collection.
Plexa is for the autologous collection.
No.
No, it's
saying,
a backup.
No. Plexafare. See, we are doing backup collection for sickle patients. Suppose it fails.
Okay.
So we have to give the cell. They are very poor mobilizers. The thalassemia patient and sickle cell patient, they are very poor mobilizer. They are just like your chemo patients.
No. If the patient is coming under the poor predictor, you can give the Plexafare. Otherwise, for the autologous collection, preemptive Plexafare is the better choice. You do the CD34 if the count is. Because see, the cost is the cost of the Plexafare is more. So if you are giving the pen, you are adding the cost to the patient.
It's not like that. I have selected my patient of sickle thalassemia. Those I am doing backup collection, and the third is the neuroblastoma autologous transplant, because they are very poor mobilizers. So in them we are using Plexafare and we are getting good yield. So what I am doing is I am giving Plexafare. This is my own experience. 6 o'clock I am giving Plexafare, and by 9 or 10 we start the collection. By like 2 to 3 hours collection gets over. And in all the previous 5-6 collection, the CD34 counts have gone up to, like earlier we were getting hardly 2 to 3 million cell per kg, and in last 3-4 patients on whom which we did the same thing, the count was like 6 to 7 in neuroblastoma, and in fact 10 million cells for sickle cell and thalassemia. This I have already sent for gene therapy, because in gene therapy you need to have 20 million cells, because it is gene therapy is like autologous transplant, right? So you have to have at least 20 million per kg. So for that, I think the USA, they've already used this, but this kind of like the timing is never mentioned anywhere. So we are doing this and we are
But
trying
this
to.
is you are doing for, I mean, I'm sorry, time is
So
going
madam,
on.
I'm just
We will
telling you
talk
that-
about this later because
Yeah, yeah.
you are saying thalassemia people are poor mobilizer.
Yeah, they are very
So,
poor mobilizers.
okay, of course they ought to be poor mobilizer, but why are you collecting for gene therapy you are collecting?
No, I'm not collecting for gene therapy.
You are doing an
No, I'm
autologous
just-
backup.
No,
You
got
are
that.
doing an autologous backup.
No, I'm saying that because gene therapy is coming up in future.
No, but
in
why are
India-
you collecting from a patient?
No, I am not collecting 20. I'm just saying you that if you do the collection like this, if you give Plarixafor at 6 o'clock and collect the cell at, within 3 hours you start the collection, finish it by 12 or 1, the volume, the amount of CD34 count is doubled as compared to the previous one.
So ma'am, sorry to interrupt you. So this is case to case basis.
Yeah.
Okay. So if you want a higher dose in a certain indication or certain patient, you give the Plarixafor without hesitation. You collect the dose, you take up as a backup and anything. Poor predictor in any kind of malignancy or any kind of indication, if it is patient fit in there, it's a rescue mobilization. You can use freely, but the gap of 12 hours is mentioned in the book because the TF of the peaking of the CD34 is mentioned in ABB. So it is there. It
So
is there
Dr.
in the book.
Amardeep, we have time constraints, so we can discuss.
Yeah,
downstairs.
sure.
Okay,
Just
continue
one
discussion.
question. See, usually we see the platelet contamination, lot of platelet contamination while collecting the stem cell. So how do you minimize this collection, the platelet contamination?
See,
there
platelet,
any
we cannot. We only eliminate the RBC contamination from the platelet, and we are worried for the RBC contamination.
In the same way, like how do you do? Is
So you can select the machine. So Optia having higher retrieval of platelet, and other Amicus machine is lesser retrieval. So you can choose the machine.
Okay,
We are mainly worried for the hematocrit, not worried for the other kind of this thing.
We proceed for the next
Yeah,
session.
sure.
Thank you.
I'm the last slide.
Thank you.
Next.
I'll request Director Sir to join us.
We shall proceed for the next session of this CME. May I have Dr. Vijay Chaudhary sir on stage for quiz? Sir, Dr. May I have Dr. Vijay Chaudhary sir on stage for quiz proceeding?
Hello. 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 Hello.
Okay, good evening ladies and gentlemen. So we are now proceeding with the quiz. I would like to invite my teams. So we have 6 teams participant for the quiz. First is team A, which is of GRMC Gwalior Pediatrics Department. Dr. Anchal, Dr. Saurabh, Dr. Anchal, Dr. Saurabh and Dr. Himanshu. Teams have come or no? Where are? Where is team B? Dr. Shreya Jain, Dr. Ankit Sharma and Dr. Nikita Avasthi. Team B is also from GRMC. Team C is again from GRMC. So Pedia department has 3 teams basically. So team C is Asmita, Dr. Kavya, Dr. Kalyani. And team D is from CHRI, Dr. Mohit Arora, Dr. Hers and Dr. Priya. Team E is again from GRMC Pedia, Dr. Mini, Dr. Vrinda and Dr. Shivani. Team F is Chirayati, Dr. Mami, Dr. Chirayu, so you settle down and I'll read out the rules first. So this is basically a 3-round quiz. Round 1 will be rapid fire round in which each team will be asked 5 questions and you will be given 20 seconds to answer the question. So each team 5 questions, 6 team 30 questions, okay, and each question you will be given 20 marks only. At the end of the question I will be reading the answer also. Now round 2nd is case based round in which we have total 5 cases. A small pen and paper is given to you. You please write your team's name, only team A, B, C, D like this, not your name. Team A, B, C, D and correct answer. Answer means whatever I have asked, diagnosis or whatever. So you have to write the name of the disease. Sorry. Dinesh Burani sir is calling. Okay. So the second round will be case-based round. 5 total such question I will be asking, and you have to write on a piece of paper your team's name, team A, B, C, D or E, whatever is the name, and the correct answer. You never write A, B, C, D, please remember. You write the name of the diagnosis. And the third round will be basically a kind of pictorial round, a little more engaging kind of round, which we call it buzzer round. So you will be given a buzzer here. Total 5, I will ask total 5 questions. Whosoever will press the buzzer first will get the answer. And one important thing I want to mention, we will be eliminating 2 teams here. So first team will be the team who will get the minimum marks at the end of round 1 will be eliminated, and another team will be eliminated at the round 2. So in final round only 4 teams will participate. Clear? Any doubt? Should we start? Timekeepers are ready?
Everybody check your mic. Say hi to everyone.
Hello. 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 Hello.
Hello.
Done? Rules are okay, clear? Should we start? Okay. So welcome to rapid fire. First round, each team will be asked 5 questions. I will be starting from team A. Team A, this is your first question. Please read it carefully. The time will start when I stop reading the question. Okay, so question 1, leukocyte alkaline phosphatase activity is found in which of the cell? A, neutrophil, B, eosinophil, C, myeloblast, D, monocyte. Your time starts now, 20 seconds.
Myeloblast.
Okay. Wrong answer. The answer is neutrophil. Right? That's team A, second question. Best therapy for polycythemia vera. Regular phlebotomy, intermittent busulfan, interferon and aspirin. 500 mg per day. Look at the dose. Your
C,
time
interferon.
No. Wrong answer. Correct answer is regular phlebotomy. Team A, third question. Don't worry, just keep answering. There is no negative marking here. Question number 3, deletion 5q is a diagnostic abnormality of
ELL.
Again, wrong answer. Correct answer is MDS. You can pass also. If you do not know, say I don't know, audience will get a chance to answer the question. And if audience asks gives the correct answer, we will give a chocolate to audience. Question number 4 to team A. Which one of the following is not a favorable risk cytogenetic marker in AML? Favorable risk. So AML has risk categories, not stages. So which one is not a favorable risk? Translocation 922, translocation 1517, translocation 821, inversion 16. 20 seconds.
Is it D, inversion 16?
No, it's wrong answer. Anybody want to guess the answer? Not a favorable risk. Not a favorable risk. Please understand. Yeah, correct answer is A, 922. Chocolate, he'll get a chocolate. Okay. So question number 5 from team A. Most common abdominal malignancy in children. Hepatoblastoma, neuroblastoma, Wilms tumor, lymphoma.
C. Wills tumor.
Correct answer. Okay. Now we'll start from team B. Team B, this is your first question. Question number 1. Which is not a late effect of treatment for childhood ALL? Late effect. A. Cataract. B. Obesity. C. Bone disorders. D. Restrictive lung diseases.
B. Obesity.
Wrong answer. Answer is restrictive lung disease. You can easily judge. We give steroid in ALL. Obesity must be there. A lot of steroids will go in ALL. Okay. Question number 2. What is the dose of rituximab in R-CHOP? Rituximab dose is fixed. No matter what chemotherapy protocol you are following, it is always the same. So what is that dose? 250, 375, 575, 475. 20 seconds only.
B. 375.
Correct answer. Question number 3. Which of the following drug does not cause neutrophilia? A. Epinephrine. B. GCSF. C. Glucocorticoids and D. Alkylating agent. 20 seconds. Who is keeping time?
A. Epinephrine.
Wrong answer. Audience want to. Yeah, it's very simple. How can alkylating agent cause neutrophilia? Ma'am will get chocolate. Okay. Question number 4. Small round blue cell tumors includes all except one.
D. Osteosarcoma.
Correct answer. Question number 5. Classical triad of retinoblastoma includes. Morning में ही पढ़ाया है.
B. Leukocoria strabismus painful.
Correct answer. Very good. Now, team C. Question number 1. MRD stands for. ये भी पढ़ाया है. अगर lecture attend किया.
B. Minimal residual disease.
Correct answer. Minimal residual disease. New name is measurable residual disease. Measurable, sorry. Question number 2. JAK2 mutation is seen in ITP, CML, CMML, polycythemia vera.
D. Polycythemia vera.
Correct answer. Question number 3. Team C. All of the following are major cell cycle checkpoint except one.
D. RNA damage checkpoint.
Excellent. Correct answer. This one was a really tough question and she answered. Question number 4. Most radiosensitive pediatric tumor is A. Osteosarcoma, Ewing sarcoma, chondrosarcoma or fibrosarcoma.
B. Ewing sarcoma.
Correct answer. Ewing sarcoma. Question number 5. This is last question. Commonest site of Wilms tumor metastasis is brain, B. liver, C. lung, D. bone.
D. bone.
Wrong answer. Audience want to give? Not liver, sorry. Yes, ma'am got 2 chocolates. Okay. Team D, your turn now. Question number 1. Bone marrow biopsy is indicated in. Please read the question carefully. Bone marrow biopsy is indicated in A. Non-Hodgkin's lymphoma, B. Acute myeloblastic leukemia, C. Megaloblastic anemia, D. Disseminated intravascular coagulation. 20 seconds only.
So A, non-Hodgkin lymphoma. A.
Correct answer. Now he thought through it and then he gave the answer. That's why it's correct. Now the answer is correct here because you can use bone marrow aspiration in many of the other conditions. But to rule out non-Hodgkin's lymphoma, aspirate may not be sufficient always. So you need to take a biopsy, a piece of bone and ISC on that. And that is why you can you rule out bone marrow involvement in any of the non-Hodgkin's lymphoma. Question number 2. In chronic myeloid leukemia, Philadelphia chromosome is present in A. Myeloid cell, B. Lymphoid cell, T. Lymphocyte, and D. All of the above. 20 seconds only.
So B.
B. You want to give B? Not correct. Any audience guess? Say answer. Say answer. All of the above. Correct answer. All of the above. Question number 3. So I want to just give a little clue towards this answer. When you have a pH positive ALL, there will be Philadelphia chromosome in B cell only. But if you have CML, all of the cell lineage will show pH positive chromosome. So question number 3. Once a unit of blood is released from blood bank, it must be completely transfused within 30 minutes, 4 hours, 6 hours, 8 hours.
So B, 4 hours.
Correct answer. 4 hours. Question number 4. What is the prognostic scoring system used in CLL? This is prognostic scoring system. I'm not talking about other thing. So Rye and Binet, Ann Arbor, Hasford, Matutes.
A, Rye, Bennett.
Okay, you want to give that answer?
Yes, sir.
Which is not correct. Audience, I told you prognostic scoring, not other thing, not staging. So audience want to give a answer? Perfect. Hasford score. Audience are. It is correct answer. C is correct answer. They also gave the correct answer. Okay. Team D, your last question. Characteristic translocation of Ewing sarcoma. मॉर्निंग में ही मैंने किसी से क्वेश्चन पूछा पोस्टर में.
B, 1122.
Which one you want to?
B.
Tell the translocation.
1122.
Correct answer. Now team E, this is your first question. Standard radiotherapy fraction size in pediatric malignancies is 4 gray, 3 gray, 2 gray, 1 gray. अभी हुआ है लेक्चर. 20 seconds.
C2GY.
Yes, correct answer. Question number 2. Craniospinal radiation is classically used in. ये भी अभी लेक्चर हुआ है. Wilms tumor, medulloblastoma, neuroblastoma, hepatoblastoma.
C. Neuroblastoma.
Not correct answer. Ma'am got. Team CHRI, ma'am. Medulloblastoma is correct answer. Question number 3. Majority of cell type in peripheral blood lymphocyte are T cell, B cell, NK cell, large granular lymphocytes.
C. NK cells.
Not correct. Audience want to... Not correct even audience. Correct. T cells, sir. T cells is the correct answer. Okay. Question number 4. A lymphoma that can be treated by antibiotics. A lymphoma that can be treated by antibiotics. Follicular lymphoma, gastric marginal zone lymphoma or maltoma, whatever you want to say. T cell histiocyte rich large B cell lymphoma, cutaneous T cell lymphoma. Pre-PG question, remember?
B. Gastric maltoma.
Yes, correct answer. H. pylori associated gastric maltomas can be treated by antibiotics. Some of them, not all. Question number 5. Rye staging system is used for AML, ALL, CLL, CML.
No prompting, please.
No prompting. Array?
No prompting, no, please.
C. CLL.
Correct answer. Please don't prompt, otherwise the fun of quiz will not be there. Na? Now team F, last team. Question number 1. Most common site for rhabdomyosarcoma in children. A. Extremities. B. Head and neck. C. Liver. D. Kidney.
No issue, you can pass the mic.
Head and neck, sir.
Yeah, correct answer. Head and neck. Question number 2. Best imaging modality for local staging of bone tumor. A. Ultrasound. B. MRI. C. PET alone. D. X-ray only.
B. MRI.
Correct. Question number 3. PCI in pediatric oncology stands for A. Posterior cranial irradiation. B. Prophylactic cranial irradiation. C. Pediatric cancer intervention. D. None of the above.
Sir, B. Prophylactic cranial irradiation.
Correct answer. Question number 4. Name the cancer with 80% or above cure rate. A. Pediatric ALL. B. Pediatric AML. C. Medulloblastoma. D. Osteosarcoma. ये भी अभी पढ़ाया है इसी.
Sir, AML.
Not correct. Audience is also not correct. ALL. ALL. मैम के पास काफी चॉकलेट हो गया आज. Question number 5. Serum free light chain ratio is associated with. This is the name of one investigation. In which disease you want to send this investigation? To assess the prognosis and also for diagnostic purposes. A. AML. B. ALL. C. Multiple myeloma. D. CLL.
Sir, multiple myeloma.
Correct answer. So this is the end of round 1, which is rapid fire round. At the end of this round, we want to give the scores. So team A got 10 marks, team B got 30 marks, team C got 40 marks, team D 30, team E 30, and again team F 40 marks. So 2 topper teams, team F and team C, while I have to say sorry to one team, team A, for now. You can sit there but you will not be participating in next round. So next round I will be asking 5 case-based questions, and you will be given a pen and paper. Remember, you have to write the diagnosis. Okay? And after that I will be checking this whether it is correct or not. Again, I will start from team B. Oh, any team can answer, na? Everybody has to write. Round 2. Who is Sherlock Holmes here? Let us see.
Anyone can answer, right?
Everyone has to answer.
Everyone has to jot down the answer.
Maximum number of correct answers will get, the topper position. Question number 1. 62-year-old male with 1 month history of shortness of breath, abdominal discomfort. On examination, he has cervical lymphadenopathy and splenomegaly. HB is 8, WBC is 32,000 with lymphocyte 78%, neutrophil 20%. Platelet is normal. Direct cum test is 4+. What is the most likely diagnosis? Your options are these 4. You will not always get the options, only few questions has the options. You have 2 minutes to write. DCT is 4+ here. Please don't listen to me, otherwise you will get confused. Again I am saying DCT is 4+. You can write only one answer, remember that, no 2 answers. So write the question number and the answer. 10 seconds. Time's up. Okay. Next question. 66-year-old gentleman has fatigue, fever and episode of epistaxis. On evaluation, his HB was 12.5, mean corpuscle volume is 89, platelet is 1,70,000 and WBC count is 62,000. Examination of peripheral blood film show many blasts with or rod. Which of the following risk factor most likely preceded the development of his current illness? I am not asking the diagnosis. I am asking which of the following risk factor most likely preceded the development of his current illness? Your options are here. 30 seconds. Ten seconds left. Please write only one answer. So question number and answer. Zero marks if you write two answers. Over. Question number 3. 40-year-old gentleman presented in hematology OPD with complaints of incidental detection of high TLC. On examination, splenomegaly was present 6 cm below costal margin. CBC saw HB of 13.2 with TLC 86,000 with neutrophilic predominant differential, and platelet is 2.4 lakh. You want to send a single most important test. What will you want to order? What will be the single most important test you want to order for this patient? One test that you want to order. No. There are no options in this question. सेप्सिस वाला लेक्चर सुना होता क्विक सोफा वाला तो आंसर आ जाता. आज ही हुआ है वो लेक्चर भी. Thirty seconds. Ten seconds. Time's up. Question number 4. 32-year-old female, avid non-veg eater, complained of fatigue, mild icterus from 10 to 12 days. On palpation, mild splenomegaly, tipped spleen is there. Again, DCT is 4+. And you can see hemoglobin 8.1, fairly normal RBC count with MCV of 115. RDW is 15.2, TLC is normal, platelet normal, bilirubin is 3.2 and direct bilirubin is 0.6. B12 is normal, folic acid normal, corrected reticulocyte count is 6.5. Again, we have another part of this question. See here, bone marrow showed 2.76% clonal B cell population. What is the diagnosis? This is tough. We recently saw this patient, was admitted in ward B. He sees well now. This is tough. So gradually the level is going to be a little harder and tough. The question is why I did bone marrow first place? Only anemia. $20. Time up. Question number 5. This is last question. 32-year-old man presented with a 3-month history of painless cervical lymphadenopathy, 8 kg weight loss. Examination revealed enlarged supraclavicular lymph node and a mild splenomegaly. A biopsy photograph from the lymph node has shown on the slide. ISC was positive for CD15 and 30 but negative for CD45. What is the diagnosis? Very simple question. You want to see the previous slide? At the end of the round, I will be coming and checking the answer there. You will sit there. सिंपल क्वेश्चन को इतना सिंपल भी मत सोचना है. सोचो मैं सिंपल क्यों डालूंगा. Thirty seconds. Okay. We'll check from here.
If you want, we can have the police go check each one's answer. Yes, sir. कोई याद है तो बता.
CLL is correct answer. MDS is correct answer. And Hodgkin's lymphoma. So 3 correct.
So team S. Hey, police. Hey, people are correcting their answers.
If you 4 से ज़्यादा एक भी नंबर है कटा हुआ है नहीं होगा वो.
we should check their score. We must check their score. They have written every answer. That's good.
Not bad. So we'll announce the numbers now. Both first and second round.
पहले second की बता दो फिर तो
हाँ.
टीम ऐप से स्टार्ट करें. टीम ऐप 30. अब टीम बी से ये भी एक नंबर मिसिंग है.
Okay. Team B, because Team A was eliminated, so Team B is 40. Team C is 20. Team D again is 20. Team E 30. Team F 30. This is round 2. स्कोर कुल कैलकुलेट करो. ये तो एलिमिनेट So team B maximum marks 70, team C 60, team D 50, team E again 60, team F 70. I do not have a tiebreaker question, but one question which was of team B was partially correct, that I will see in the end. If I want to give benefit to you, I will give.
So team which is eliminated? D.
Team D. So we are eliminating team D. Now we have team 4 cross
I think
mark.
for clarity teams can move down.
Yes.
We'll request team A and team D to join the chocolate
Group. Buzzers, can we check the buzzers please? Answers, okay, yes. So this is clear-cut Hodgkin's lymphoma, everybody knows it. Now this question is actually secondary hemolytic anemia. It is hemolytic anemia, but it is secondary. And this question is either you want to send a FISH for BCR-ABL or RQ-PCR for BCR-ABL, whatever. And this is MDS, question number 2. And this is CLL. CLL can cause DCT positivity. It can present with secondary hemolytic anemia. So buzzer check किए. आप बताएंगे ना कौन सी टीम ने पहले होता है? कहाँ दिख रहा है? मुझे नहीं दिख रहा. फिश फॉर BCR-ABL या RQ-PCR फॉर BCR-ABL? तुमने फिश लिखा है? आई एम नॉट. सो वेयर इज योर सीट? नो नो, लेट मी सी. वो उसमें लिखा है नो, दिस इज फिश ओनली. Fish for BCR-ABL. You have to write the answer. Yes. Fish, you can do many things. Deletion 5q you can do with fish. You can do HER2 testing by fish. Okay, so buzzer कहाँ दिख रहा है?
लाइट जलेगी.
कहाँ जल रही है अभी लाइट? एक दबा के देखो. मुझे क्लियर नहीं दिख रहा, तुम देखना ठीक से. Okay, so we are starting. Okay, please don't do cheating. उधर से डॉक्टर साहब आप एक बार देख लेना किसका पहले जगह. मेरा यहाँ से ठीक से दिख नहीं रहा है. ठीक है, ठीक है. वैसे भी क्वेश्चन इतने आसान नहीं होने वाले. इसके लिए कितना टाइम है? 2 minutes. यू कैन थिंक, है ना, काफ़ी टाइम है. क्वेश्चन नंबर 1. लिंक द इमेजेस, आइडेंटिफाई द जेंटलमैन. 1984 Nobel Prize in Physiology and Medicine. सारी इमेजों को जोड़ के और नाम बताओ. Even the audience will get double chocolates if they can tell.
How much time for one question?
2 minutes.
We'll keep it 1 minute.
हाँ, ठीक.
1 minute.
I'm sorry, I'll give you only 1 minute to answer, है ना? Everybody, quickly do. If nobody can answer, then the question goes to audience. 10 seconds left. No negative marking. Time's up. Audience, please.
Apollo?
Please stand up and tell. No. No. This is one drug, Darzalex, which is monoclonal antibody. This is your het medium, famous medium. MBBS में पढ़ते थे ना, hybridoma कैसे बनाते हैं. So now who made hybridoma? Who made monoclonal antibody? Caesar Milstein and George Kohler. So this is the correct answer. And they got Nobel Prize in 1984 for discovery of monoclonal antibody by hybridoma technology. Okay? Question number 2. Again, identify the gentleman. Again, Nobel Prize in Medicine 1930. थोड़ा सा दिमाग लगाना है. 1 minute you have. Go back to your MBBS days. Thirty seconds left. Anybody? No negative marking. कोई तो बताओ ना. अभी बोलूंगा तो कहोगे इतना सिंपल था. 5 seconds. Okay, done. What is this? Audience answer? Carl Landsteiner, rhesus monkey, hydroxypetalus. So we have the audience answer. Excellent. Chocolate उधर मिलेगी. Very good effort. Third question. Again. Which team? Team C. Yes, please. It's loudly. Mike.
Professor Burkitt.
Correct answer. I'll give mark. Dennis Parson Burkitt. Because he discovered African or endemic Burkitt lymphoma. This is he with image of Africa. This is the microscopic picture. Again, you can see jaw tumor here. So team C got 1 correct. Next, fourth. Link the image and identify gentleman. This is tough. This is one procedure which we do all in medicine, pediatrics, hematology. And he is Indian too. Please understand this. He is Indian. Team F, yes.
Yallapragada Subbarao.
Yes, correct answer. Excellent answer. Okay. Question number 5. First targeted therapy of modern oncology. Name the drug. Remember, you have to give me the name of generic name of the drug, not the brand name. Team D.
Tyrosine kinase inhibitor, imatinib.
Imatinib is correct answer. Imatinib mesylate. If you would have given me tyrosine kinase only, there was no mark. So now score is what? Tiebreaker लगाना पड़ेगा. So results are Team B 70 marks, Team C 80 marks, Team E 60 marks, and Team F 80 marks. So two teams, Team C and Team F, 80 marks.
Tiebreaker for runner-ups also because we have only first, second, third.
First, second, third, yeah,
तो
okay.
पहले runner-up का tiebreaker फिर winner का.
But I have only one question, I think.
We'll ask another question.
Okay, again. Change आ रहा है? How? हाँ तो ठीक है.
इसमें एक सर अपन ने मिस कर दिया था ना कि 5 साइड पे कर दी 70 मैम आपने 70
30 plus 40 हाँ
70
हो गए. एक इसमें सही आंसर
सही किसने दिया
नहीं दिया ना सही.
नहीं दिया एक
टीम ने दिया था. नहीं दिया.
नहीं दिया
नहीं टीम डी ने दिया है वो. टीम डी ने. हाँ तो टीम डी ने एक दिया.
सही हो रहा है. सही है.
सर देखो
टीम सी का 70 है.
60 है और इसका 80
Team B is 80 marks, Team C is 70 marks, Team E is 60 marks, and Team F is 80 marks. So tiebreaker question, and we have half of the marks for your that question. Okay?
no half mark, no computer.
Okay. ठीक है. Link the images and identify the drug. Now this is open for everybody.
But they will answer first.
Yeah. Yes. Team B.
Louis Pasteur.
Where is Louis Pasteur, man? Here, buffaloes are there. Done? Ten seconds. टाइप ब्रेकर वाला तो कोई नहीं बता पाया. नहीं, wrong, no negative mark. Time's up. Audience, warfaring. Correct answer. Okay, so because there was a plant, and then plant, you know, the cattle used to graze on that plant, so they, they, they got killed by bleeding. And after that, the extract of that plant was used as a rat poison. And in Wisconsin University, they have extensively researched and extracted the extract and used as warfarin. So therefore, a cattle's rat poison and W, Wisconsin University is written here. But unfortunately, we do not have a tiebreaker question. Ma'am, you want to ask anything? One tiebreaker.
Teams were competing.
Two teams. B and F. F.
Both are at
80 marks. So only B and F has to answer.
And this will be a single question.
Singles.
Or we want 10 questions. Okay. B and F. You want hemat or you want pediatrics? Which question you want? B and F, right? So you want hemat or you want pediatrics?
Anything will be fine.
Anything? Hemat? They are prompting.
Obviously they want hemat.
Achha. Easy question, difficult question. So I'm going to ask question from what we discussed today, okay? Name one solid organ malignancy where bone marrow transplantation is indicated. Solid organ malignancy where bone marrow transplantation is indicated. He has said Ewing's, that's not the right answer. That's only experimental, not standard.
RCC?
No.
Wilms?
One answer only, huh? Okay, next question. We'll ask something from oncologic emergencies. A patient is coming to you, known case of say Ewing sarcoma, and the patient is having loss of power in both the lower limbs. The history is spanning for say 2 days. While you are awaiting maybe an onco consult, a neuro consult, a radiotherapy consult, what is the first golden drug to administer? Yeah, very good. That's the correct answer. And that's an emergency. So not only he gets the prize, he saves a life also. Thank you.
Thank you, ma'am, for saving me also, because I have only one tiebreaker question, but that warfarin was really good. Excellent. Okay, so the winner is Team F is the winner. Second place is Team B. Please put a big hand. And third place is, of course, Team C. Excellent. No, that's it. Identify gentleman towards my right. That should be the tiebreaker. Professor Maman Chandi. He has established first bone marrow transplantation unit in this country.
So I'll request the team members to please take their space in the hall. We'll move on to
made this conference a grand success. One of the highlights of this conference has been the outstanding scientific contributions presented through paper and poster sessions. The dedication and efforts displayed by all participants was truly commendable. So, without further delay, we move on to the much awaited announcement of the winners. For the poster presentation, the second prize goes to Dr. Ayushi Guru. Can you please come on stage? And I would like Dr. B.R. Srivastav sir to please present the certificate.
For the valedictory, I'll request Director Sir Dr. B.R. Srivastav, Dr. Pankaj Gandotra Sir, Dr. Jalaj Sir to please come on the dais. And Dr. Nidisha Ma'am, please join us. Dr. Anil and Dr. Vijay, please join us.
Okay. The second prize for the poster presentation to Dr. Ayushi Guru. Please give a big round of applause. Okay, now for the first prize. The first prize goes to Dr. Kavya. Can you please come on stage? Okay. Coming to the oral paper presentation, the second prize goes to again Dr. Ayushi Guru. Please come. Can you please come on stage?
Dr. Ayushi is going to give us a major treat, huh?
Yeah. The first prize goes to Dr. Vrinda. Okay. Coming to the results of the quiz competition, the third prize goes to Team C. Can Team C come on stage? Okay. So Team C is the Department of Pediatrics in GRMC with Dr. Asmita, Dr. Kavya and Dr. Kalyani. Okay, for the second place, I call upon team B, Dr. Shreya Jain, Dr. Ankit Sharma and Dr. Nikita Avasti. Coming to the winners, Team F, that is the GRMC Radiation Oncology Department, Dr. Chirayati, Dr. Prudvila and Dr. Chirayu Mohan Tiwari.
सारे क्विज पार्टिसिपेंट्स भी ग्रुप फोटो के लिए बुला लो. ठीक है.
I would like to request all the quiz participants to come on stage for a group photograph. Okay, all the participants.
Please come quickly. All quiz participants. It was wonderful, huh? They were very difficult questions, even I couldn't answer. वो Warfarin और Louis Pasteur कभी पता नहीं चलती. A big round of applause for all the quiz participants, please.
Congratulations to all the winners and participants for their excellent presentations. All the participants can collect their certificates from the collection booth after submitting their pre and post tests. And I would also like to request everyone to please share their thoughts and kindly fill the feedback forms. Now I would like to call upon stage Dr. Vijay Chauhan sir to kindly offer the vote of thanks.
So at the end of this wonderful CME, a full day session of academic feast, I would like to Thanks all the patrons, all the participants, delegates, faculties, sponsors, and the organizing team, and our volunteers who worked really hard from last 1 month to successfully complete this final mission. Thank you very much.
Well, now we are coming to the end of this historical CME. Historical in the sense that it is the first CME in town of Gwalior on pediatric hemato-oncology. I really wish to thank all the faculty members and students of PG College of Nursing for taking active part in this conference and gracing this occasion till the last. I am thankful to the all participants who have come from JR Medical College and other institutions to take part in the quiz competition and attending this conference till last. Many thanks to the faculty of Cancer Hospital and Research Institute, Gwalior. They have taken active participation, keen interest in making this conference a very big success. Any event cannot be completely held successfully without cooperation of the other staff, right from electricians, AC people, Safai Karmachari, Bard Boy, supervisory staff and technical staff. Everybody has worked very hard to make this CME a successful event. आप लोगों की कह रहा हूँ देवेंद्र आ जाओ अंदर आ जाओ. एसी अच्छा चल रहा है. आप लोगों की तारीफ कर रहा हूँ कि आप लोगों के सहयोग से वो जो लड़के खड़े हैं ना उनको भी बुला लो. उनको डर लग रहा है उनको क्यों बुला रहे हैं. आप सभी लोगों के सहयोग से और जो सुपरवाइजर्स वगैरह बाहर बैठे हैं ये कॉन्फ्रेंस इतनी सक्सेसफुली आयोजित हो सकी. देखिए कोई भी कार्यक्रम होता है तो सभी के सहयोग से होता है. दिस इज ट्रू. बट यू ऑलवेज नीड ए लीडर हु गाइड यू, हु असिस्ट you and who supervise and work very hard to make that event a success. And the person behind the success for this conference is Dr. Gunjan Srivastav. So I think she deserves a standing oration. So I request from you all to give a standing oration to Dr. Gunjan for organizing such a successful conference, of course with the help and guidance and coordination of everybody, whether it is Dr. Chaudhary, Dr. Anil Sharma, everybody, all faculty members. But as I said that you always need a person who take a lead, and she has taken a lead, and I hope that she will able to organize much more successful conference what she has organized this time. So congratulations to Dr. Gunjan once again. Well, that's all I wanted to say, that for this successful event, everybody has contributed and they all deserve congratulations and my gratitude and thanks. Well, we have already, for national anthem.
don't start with dinner, in the meantime, you can have the tea that we didn't allow you to have before. Thank you so much. Thank you, everyone.